Okay. All right. Good morning. How is everybody today? Good. Happy Monday. It is the last Monday of March, though, so we have April coming up. All right. So over the weekend, you had 2 chapters of homework, chapters 2 and 3, and I know they were long. They were long. I get it. When I call your name, hopefully you graded them. Okay. If you using the answer key at the back of the book, and then you've got your grading scale there at the bottom. So if you use the grading scale and you know your percentage, tell me. If not, just tell me how many you missed when I call your name. If you did not get to it, just say pass, and I'll ask you again next class. Victoria, for both? Thank you. Tempest? Jayland?
I got 1 wrong on chapter 2 and I got 4 wrong on chapter 3.
Okay, thank you. Serena? Brigitte? Monica?
I got 100 on 2 and I missed 2 on chapter 3.
Thank you. Kaya?
100 on chapter 2 and then missed 2 on chapter 3.
Okay, thank you. Arjola? Ito? Bobby?
-1 on the first chapter, -2 on the second.
Thank you. Jyothi?
Yes, Mom.
How did you do on your homework? Yeah, and you don't have your book with you. That's fine. That's fine. Deja?
Chapter 1, 100, chapter 2, 95.
Thank you. Okay, so you said you missed 3?
No, chapter 3, I got a 95.
Okay, all right, got it. So those of you who missed any questions, do you have any questions for me on what you missed? Do you know why the right answer was the right answer and the one you chose was not right?
Mine was just the ADHD for the long. You gotta pick the ones of it.
Yeah, and one of the things that the practice test that I'm working on, and it will be done by the time, probably I would say next week I'll be able to send it out to you guys to be able to review it. It's getting longer because there's going to be over 250 questions in it, but most of them are guided. So I'm showing you what the keywords are, what the concept is that they're testing you on, how to choose the right answer. And it really boils down to, on the state exam, there's really only about 10 things that you need to know to pass the test. That's really what it boils down to. So it's, once you go through this, I make the written test become super easy because you'll look at the question, you'll be able to decode it. Now, the one thing I can't do is get you to slow down, because what ends up happening, and a lot of times, is you read the question and then you read the first answer and it looks right. So you go with it and then you move on. Well, the problem is the way these questions are structured, that first answer is often designed specifically to trip you up. It is put there on purpose in that position. There's nothing random about it, because as CNAs, we can't have that kind of mentality. We can't go into a room, think something, and lock it in, right? We have to collaborate with the nurse. We have to get more information. It's very important that we look at everything. Does that make sense? So those of you who kind of struggle with that, you read the question, you look at the first answer, and you pick it because it looks good enough and move on. My practice test is designed to get you to slow that behavior down. So it will help you with that as well. Okay. So hopefully that will help you. And I'm hoping, keep your fingers crossed, to have this dialed in this week so that I can distribute it to you guys next week. Now, the thing that I'm going to ask from you is feedback from that practice test. I'm giving it to you guys for free. It will not be free for the world. I'm putting a lot of time and effort into this. It will not be free. So you guys will get it for free, but I'm going to need some feedback from you. Does that sound fair? So the cost is your opinion. All right. But no questions on chapter 2 or 3. Okay, we're going to get into a review here. This is going to take me probably about 25 to 30 minutes to review everything that we learned all of last week, because we had a whole weekend in there, and there's a lot going on, and you probably forgot a few things. Some things slipped through the cracks. So I'm going to refresh your memory on all of this before we go into today's lesson, because we're going to build on what you've already learned. And if we don't remember what we learned, then what I give you today isn't going to help. Good? Good. How do we know what to do with each patient? We follow the care plan. It's not just the care plan, it's the whole care plan and nothing but that care plan. Don't add to it. Don't take away from it. It is the care plan. It is written in stone. What do you do if you can't follow the care plan? Tell the nurse. While we're following that care plan, we should be making observations. And what do we do with those observations? We report them. Yeah, so remember that everything the nurse should know. Now, most of the time, that's going to be very routine, right? The patient doesn't change depending on what setting you're in. So there's not much to report, right? The patient is the same today as they were yesterday, as they were last week. Nothing's really much changed. But if today your patient is sleepier than normal, is that a change?
Yes.
What do we do with changes? We report them. Yeah, we report anything abnormal. So on the state exam, if you see a word like change, suddenly, new, okay, those are all things that need to be reported. So your correct answer there is going to be notify the nurse, report it to the nurse, right? So you're going to look at that question for words like new, change. And if you see that, you know that if we have new information, the nurse needs that new information. Make sense? That's going to take care of probably about 30% of the questions on the state exam. Look for new, change, abnormal, different. Notify the nurse. Now, the one exception to that, there is an exception to that. Emergencies. If there is an emergency, if your patient is in jeopardy of any kind, we have to act first. So do something to get your patient safe before you notify the nurse. Does that make sense? Good? Okay, you're going to get an extra handout today at the end of class. Jake, can you give me the pink handout, please?
Terminology?
Yeah, please. So you're going to get this extra paper. Now, I made this up last class. I try to make something new all the time, but you're going to get this. Okay, and this kind of goes over, because your homework tonight is chapter 4. I don't like chapter 4 in your yellow book. I just don't like chapter 4. I think it's unnecessarily complicated for you. CNA, it's all on body systems. Body systems are made up of organs. What organs go in each body system? None of that is on the state exam. You don't need to know which body system your esophagus is in as a CNA. Not relevant. But you do need to know what normal changes are for the esophagus, because if we know what normal is, we know we have to look out for abnormal, so we know what to report. Make sense? That's what all of these are. These are normal changes of aging. So I took chapter 4 and kind of distilled it down into something that's a little bit easier to digest. But around the edges, this is what I want to bring to your attention to. Around the edges are these little icons. This tells you what to do in an emergency. If somebody can't breathe, we sit them up. If somebody is unconscious or throwing up, we turn them on their side. If somebody is coughing while we're feeding them, you stop feeding them, right? That's an action. If somebody is weak and it looks like they might fall, Get them on the floor. Sit them down where you're at. Don't try to rush them back to a chair. If they aren't tolerating a slow walk, what makes you think they're going to tolerate a rush back to a chair? They're going to fall on the way. Get them sitting on the floor. If patients are sitting on the floor, they can't fall on the floor, and fall is where things happen, right? So get them in a safe position. If you notice somebody is on the ground, try to figure out, do they have a pulse? Are they breathing? Do they need CPR? Don't just run and get a nurse, because that whole time your patient is without circulation. Make sense? Good. So these icons are all of your emergency actions that kind of go with that act for safety. Good. So this kind of sums up chapter 4, this paper that you're going to get to today. All right. All right. So we record all observations. Every skill that we do starts with the opening. What does every opening start with? A knock. Correct. Correct. So we knock and we wait for them to say come in, or for the test, you don't have to wait. You can just knock and enter. But in a clinical setting, please wait for somebody to, allow you entry. You don't know what's happening on the other side of that door. Yeah. So once you've knocked, you're going to greet the resident nicely. Good morning, good afternoon, hello, hi, how are you? We're nice. Once you've greeted the resident, you're going to identify them how? By name. Say their name. Absolutely. What do they need to know about us? Right, introduction, our name and title. Hi, I'm Patty, your CNA today. After you've introduced yourself, you're going to explain the skill, the task that we're going there to do. I'm here to whatever. Read it right off the care plan if you need to, but you can also put it in your own words. Stay professional though. Okay, stay professional. Don't use slang like I'm going to wash your hoo-ha. We don't want to do that. Okay, I'm going to clean you up down below. I'm going to do peri-care, personal care. That's all fine, but try to keep slang out of it. Make sense? Professional. A word on professionalism. I usually cover this a little bit later in the program, but it's kind of important that we do cover this. You guys all want to be paid well. This is a hard job, right? You want to be paid commensurate with what you're doing. If you want professional pay, you have to act professional. If you show up in ratty scrubs that don't match and have holes and stains and tears, if you don't care about your appearance, if you are catty with your coworkers, if you use a lot of slang and cultural jargon, you are not going to be seen as a professional. They will reflect that in what they offer you for pay. I'm not going to pay professional wages to somebody that doesn't exemplify professionalism. So as a industry, if CNAs want to get paid better, you have to hold each other to account and make sure you're raising the image of your profession. When somebody says something like, oh, you're just a butt wiper, that is a reflection of how your industry has presented itself. That is not what we do. We help patients with personal care, but we are not butt wipers. We are nursing assistants. We assist the nurse. We make observations. We see to the well-being of the patients. We help them with things that they cannot do themselves, and we support them emotionally. So when somebody says that, make sure that you correct them. No, I'm a nursing assistant. I'm there to help patients and nurses. And while personal care is something that I do, it's not the total of what I do. Please don't degrade me. That's how you raise the professionalism, the standard of your industry. Does that make sense? And that's what this is talking about. When you're introducing that skill, you can read it off the care plan or put it in your own words, but remain professional.
Is it best to dress professionally when you interview? Or
We're going to talk about interviewing in detail on the last day of class. But yes, there is an old saying, dress for the job you intend to get, which we intend to become a CNA. So scrubs are appropriate, but they have to be neat, clean, pressed, solid color, no prints, and no tears or holes, or, basically the best possible image that you can present. You can also wear business professional. That's fine too. But they've got to be able to picture you in that role. Okay, good. All right. So once we've explained to them what we're there to do, what are we going to get from them? Consent, permission. Yeah. Is that okay? Yeah. Yeah. We have to get something from them, a paycheck. What am I here for? Yeah. Exactly. So yes, we want to make sure that they're on board with whatever it is that we're going to do. Now, a lot of people, especially when you're working with dementia patients, will skip this step. They don't get consent from dementia patients. And then they get upset when they start to handle the dementia patient and take their clothes off. And I want you, for just a minute, we're going to do a little mental exercise here when it comes to dementia. Okay. Does anybody here speak Russian? Anybody here speak Russian? No? Okay. I want you to imagine that you go to sleep tonight in America and you wake up tomorrow morning and you don't know what happened overnight, but you are not where you went to bed at. You open your eyes and nothing is familiar. You're in a strange room, never seen it before in your life. You are surrounded by strange people that you have never met, and they're all speaking Russian, a different language. You can't understand what they're saying. And they're giving you commands, and you can't understand what they're saying, so you can't comply with the demands. Now, all of this change at one time, happening like that, you are going to be confused. You are going to be resistant. You are probably going to get a little violent. Now, in that situation, have one of those people start to take your clothes off. You have no idea why, because you can't understand what they're saying to you. And they start to undress you. You will automatically assume that they do not have your best interests at heart. They are there to do something that is going to hurt you. What are you going to do? I'm going to fight back. I am absolutely going to fight back because I don't know what's happening here. And I'm not going to lay still and let you do whatever it is that you got planned. I'm going to fight back. That is the reality of your dementia patients. When they woke up, they have no idea where they're at because the last memory they have is from 1982. They have no idea who you are. Even if, Jake, there we go. Even if you were cared for them yesterday and the day before, it doesn't mean that they remember that. Right? So they are in a strange place. They are surrounded by strange people. And in a very large majority of the cases, they do not understand your words. So you go in and you just skip talking to them because they don't get it anyway. And you start taking their clothes off and you wonder why they get aggressive. And then you label them. Oh, they're not compliant. They're aggressive. They're mean. She's got dementia. Don't worry about it. Just go in and do what you need to do. Have somebody hold her down. She already thinks she's being assaulted. And now you're putting a second person in there to hold her down? You do this often enough, and that person isn't going to trust anybody. Anybody. And now we have a combative patient. because we never stop to put ourselves in their position. We never thought about what life was like for them. We assume they're having the same day we are. They're not. Do not skip consent. If you can't, if you're talking to a patient and it doesn't seem like they're getting what you're saying, say it a different way. Approach them a different way. Try to get them on board with what you're doing before you start doing it, even if it takes a little extra time. Because if you don't, the long-term ramifications of this are extreme. Your patient will not trust anybody. Anybody. And now every care we have to do becomes a battle. One bad caregiver is all it takes to set this up. And I can tell when I go into a memory care unit, a dementia unit, I can tell the way the staff treats the patients without ever meeting the staff. If I have patients that all react to the same thing the same way, it tells me everything I need to know about that staff. That's you. What you do matters. This isn't just an exercise for the test. This isn't just something we have to memorize to be able to pass something. This is real. This matters. And if you don't set your encounters up the right way, your job is going to get exponentially harder. Make sense? This obtained permission, way more important than you guys think it is. Way more important. Okay? So after we've gotten permission, then we can close the curtain. Is that curtain clean? No, absolutely not. So what do you want to do? Wash your hands. After you've washed your hands, you can go get your clean supplies. Don't get your supplies first. You have to wait until you've washed your hands to get your supplies. And your supplies are always located on the bottom of your skills page. You have to learn these. We haven't really talked much about that. But during the exam, if you have to do hand and nail care, and what's your name? Victoria. So Victoria has to do hand and nail care on a patient. As the nurse, I'm going to say, Victoria, go do hand and nail care. I'm not going to say, Victoria, go do hand and nail care, and you're going to need to take with you a basin, 2 washcloths, a towel, soap, lotion, emery board, orange stick, barrier for the table. I'm not going to list off what she needs. She should know what she needs. I should be able to say, go do hand and nail care. So this is a question I get on the test all the time. You mean I have to memorize all these supplies? Yes. Yes. If you're going to do the job, you have to learn the supplies. Flashcards help. So if you've not made flashcards, you should on your supplies. We do have them. You can get them from me if you want them already made up and in full color. That's fine. But if you do them yourself, the act of writing helps you remember. Okay, good. But I do have them. All right. Our cardinal rule here is do not touch that patient until your hands are clean. Remember that patients have an immune system that is currently compromised, busy. If you bring them something that they don't already have, they may not be able to fight it off. So do not touch your patient until your hands are clean. Super important. So after we've done our opening and we're thinking about our supplies, the first supply we should consider is gloves. Now, we're not just going to grab gloves for everything, because when you do that, you stop paying attention to what you touch with your gloves. You stop. That's a problem. So we don't wear gloves for everything, but we do wear gloves if we're going to touch body fluids, personal skin, or non-intact skin. If I'm going to touch any of those 3, I need some gloves. If the answer to any of those is maybe, wear gloves. There's a possibility there. But if I'm doing pulse on a patient, there's no body fluids, there's no personal skin on their wrist, and there's no non-intact skin, I do not need gloves for that skill. Good? Questions? So you have to figure out, do I need gloves for this? If you do wear gloves, the very first thing they should touch is the patient, not the supplies, not the environment. Keep those gloves clean for the patient. So let me put this on to you guys. Let's say that I'm coming to your house tomorrow morning and I'm going to brush your teeth, whether you like it or not. All of you are going, I can brush my own, thanks. I don't want you in my mouth. That's weird. Your patient feels the same way. If they can brush their own teeth, they will. They don't want you in their mouth. That's weird. But let's say that I show up and I'm insistent and I'm going to brush your teeth. Do you want me to put gloves on before I walk in your door, touching your door and the bathroom door and the toothpaste cap and everything else in the environment before I put those gloves in your mouth? Either do your patients. First thing those gloves should touch is the patient. Okay. After you have touched the patient, though, your gloves are considered contaminated. Be careful about what you're touching in the environment. Don't spread that contamination everywhere. Okay. Be careful about what you're touching. When you remove the gloves, we remove them all. I forget to do this. Hold on. Be careful about what you're touching. You don't want to spread contaminants all over your environment. It is a graded checkpoint. And when we remove the gloves, we pinch up at the cuff, pull that one off, and then go underneath to pull the second one off. So pinch up and go under. You are graded on how you take your gloves off. Now, when we're talking about supplies, we need a clean place to put them. And that's what a barrier is for. A barrier is a clean place to put our clean supplies. Our table is not clean. So we do our opening, knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Wash my hands. And now I'm going to get my supplies, but I'm going to need a clean place to put those supplies. So I'm going to start with a barrier. There we go. Start with a barrier. So you have to have clean hands to get your clean supplies, and your clean supplies cannot touch your uniform. They cannot touch your uniform. That is really slow. Why is my Stream Deck slow, Jake?
The internet is too right now.
Huh.
Both computers seem to be struggling for some reason.
Weird. Okay, well, we'll do what we can. All right, so I've washed my hands. I go get a barrier. I put the barrier on the table, and then I go back and get the rest of my supplies and put those on the barrier. Don't try to do it all in one trip, because remember, one of our cardinal rules is that we cannot let the supplies touch our uniform. Your uniform is not clean once you start work. Okay. One of the supplies that you may decide you need is a privacy blanket. We use a privacy blanket for warmth and privacy. Remember that your experience with temperature is different from your patient's. So warmth and privacy. And we use a privacy blanket anytime a patient is uncovered or undressed. Okay. You're going to put the privacy blanket on over the sheet and pull the sheet down underneath so the patient is never completely uncovered, even during that transition. Patient's always covered. And then when you're putting it on, don't snap it or shake it. That just takes all of those pathogens, puts them right up in the air where you can breathe them right in. And we do this at home, don't we, with our sheets? We do the whole snap thing to get the sheets to spread out over the mattress. Well, you are also aerosolizing your dead skin cells, your yeast, your bacteria, all the stuff that you shed at night. If you've ever vacuumed your mattress, you know what I'm talking about. It's eye-opening. But you're only breathing in your own funk at that point, right? I don't want to do that with other people's funk. So don't snap or shake your sheets when you're putting them on the bed. Just lay them out. And then when you go to remove the privacy blanket, if you are doing a skill that required gloves, so pericare, catheter care, partial bed bath, if you've got gloves on your hands, do not pull that sheet up next to their face with those gloves. Those gloves are soiled. Think about where those gloves have been. In armpits and in groins. Do you want armpit and groin covered gloves next to your face? Your patient doesn't either. So you remove the privacy blanket and pull the sheet up after you remove the gloves. Good? Good. All right. Great job. I'm going to scoot over here just a little bit. All right. So one of the other things that we learned were linen rules. Now, most of these linen rules are repeats of something that we've already learned. Like linens can't touch your uniform. Yep, we already know that. That's an infection control thing, so it counts really big. You have to have clean hands to get your linens. Yep, we've already learned that too. And again, infection control. So this is going to count really big. We don't snap or shake linens. Yep, we've learned that before. Infection control counts really big. Now, the next two we're going to cover in a future lesson, but we did learn the last one. Anything that we don't use, we're going to discard. We don't save it in the room for later. Okay. We'll learn these other two later today. All right. And then we learned the closing. The closing is done at the end of every single skill that we do. And it sounds like, thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? I always thank my patients because if it wasn't for them, I wouldn't be getting a paycheck. So I take the time to thank my patients. Thank you. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Your environment's clean, bed is in the low position. Open the curtain. Here's your call light. I'm going to go wash my hands. So that's what the closing sounds like. Now, all of you, by this point, a week in, should be able to recite the opening and the closing without any notes. If you can't, you've got some work to do. And I would suggest you start here. Everybody wants to jump in the skills. Remember, this is part of the skills. If you don't know this, you can't do pulse. Okay, good. You have to know your opening and closing. If you don't, write it on your bathroom mirror. Every time you walk in that bathroom, read that opening before you go to the bathroom and do what it says. You've got everything you need right there. You've got a person to talk to, the one in the mirror. You've got a curtain you can close, that shower curtain, and you got a sink to wash your hands. And then go to the bathroom, and then before you leave that bathroom, you say the closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Environment's clean, bed's in the low position. Open that curtain and wash your hands. If you do this every time you go to the bathroom, you will practice this 6-7 times a day without really having to add anything new into your schedule. Okay. It's a great way to get used to practicing. Now, I go to a state convention every year, and it's coming up in about 2.5 weeks. I'm really excited about this. But I am their celebrity guest. And it's HOSA, Health Occupation Students of America. And I get to see students from all over the state that have been watching our videos all year long. And they're super excited to see me. It's a lot of fun. And about 3 years ago, I was in the bathroom at HOSA. And I heard somebody, as they walked in the bathroom, go, "Hi, Miss Jones, my name." And they did the opening because they were so used. The instructor had said the same thing that I did. Every time they walked in that bathroom, they said the opening. And that's how they learned the opening. And I came out of the stall and she looked at me and her eyes got real wide. And I said, "Great job. Great job. You did it perfect." So this is how you learn, is through repetition. If you don't put the time in, you're not going to learn it. All I can do is teach you. I can't make you do it. Okay, good. All right. So the steps of the closing is we ensure they're in a clean environment. We make sure the bed is in the lowest position. We ask if they're comfortable, and they need to hear this word, comfortable. This is a graded checkpoint. You have to say the word comfortable. And part of that is going to be addressing preferences. So would you like a magazine is fine. You want to make sure they're covered. Clothing or sheet, make sure they're covered. Open their curtain and give them their call light. Now, I don't care what order you do those things in. Order does not matter on those things. Once you've done all of those things, though, then you have to wash your hands, and this is where the order does matter. You have to get all of that done before you wash your hands because you're washing off their cooties. Once you've washed your hands, then you can chart if necessary, and then we'll wash our hands again because our checkpoint is end skill with clean hands. So if you get all done with your closing and you documented and you washed your hands and you looked at the patient and you realized that their curtain wasn't open or their sheet wasn't on or they don't have their call light or they're not in the middle of the bed, something triggers, there's something else I need to do. And you go back to that patient and you do that thing. So you get the checkpoint, right? You give them their call light, you open the curtain, you get them in the middle of the bed, you take care of the patient. What do you need to do before you end your skill? Wash your hands. Don't ignore the patient. Don't think, oh, I'm not going to give them their call light because I don't want to wash my hands again. You've ignored your patient. You've neglected your patient. That's going to count way bigger. Okay, good, good. All right. Don't recontaminate. Okay. Now, those were the principles that we've learned, but we also learned a few skills. So let's review those skills really quickly. One of the skills that we reviewed or that we learned was washing hands. So when we wash our hands, we're going to wet our hands before we put soap on. When you bring them together, that's when your timing starts, and you're going to rub all surfaces for at least how long? 20 seconds. That's the tops of the wrists, the backs of the hands, and between the fingers, and between the thumb and index finger, the bottom of the hand by the pinky, the palm of the hand interlaced, all of those areas for at least 20 seconds. After you've washed, then you go down to your nails, and you circle your nails on the palm of your hand, and then you can rinse. When you rinse, don't touch the sink or the faucet. You can step outside if you need to take that. You're welcome. So don't touch the sink or the faucet. After rinsing, you're going to tap to keep the water confined in the sink, and then you're going to dry with as many paper towels as it takes to dry your hands. Throw those away. Get a clean, dry paper towel to turn the faucet off. We're going to do that at the beginning and the end of every skill we do. Every skill. Wow, it's really, really slow. Yeah, I'm even glitchy. Mm. Thank you. Okay, so pulse. We learned this on Wednesday. A pulse is a measurement of how many times the heart beats over 1 minute. So when we're taking a pulse, normal is between 60 and 100. We use our fingertips, not the flat area of our fingers, and never our thumb. Radial pulse is located at the top of the wrist, way up here where the thumb, where the bendy parts of your wrist, where your thumb and arm meet. Okay. So we find our pulse. If you put your thumb on the back, it creates consistent pressure. For the test, you're going to tell the evaluator when you start and stop. So you'll say start when you start counting, stop when you stop counting. And for the test in Florida, you have to count with both evaluators. This is a documentation skill. Don't forget, if we count it, we must write it. We also learned how to dress a resident with a weak arm. So we're going to ask about their clothing preference. What do you want to wear today? And we're going to try to honor it. Now, our care plan is very specific, though. Our care plan says long sleeve, button or snap front shirt. So for the test, the evaluator, this is done on a mannequin. So the evaluator is going to play the voice of the mannequin. The evaluator is going to say, I want my blue shirt and blue pants or whatever it is that matches that care plan. They're not going to throw you a curveball. They're going to describe the outfit in the care plan. It's your job to get that outfit. Okay. We're going to lift from below with a flat palm. Oh, I'm sorry. Let me back up. Privacy counts with this skill. Even though we're getting them dressed, privacy still counts. So privacy curtain, keep them covered, and get their clothes before you undress the patient. Don't undress them, leave them there naked, and then go get their clothes. That's uncomfortable, okay? Lift from below with a flat palm when you're lifting extremities. Make sure you don't overextend or force movement. And everything should fit correctly. Toe seams over the toes, pants over the backside, tag in the back. Shirt buttoned or snapped appropriately, not all cockeyed, right? We want them to look nice. Keep them covered as you dress them. Only remove the privacy blanket after they are covered. One of the biggest issues with this skill is people think they close the privacy curtain and then they don't respect privacy at all. They pull the sheet down. They completely undress the mannequin. You got a naked mannequin laying here, and then they dress the mannequin. They will not grade well on that. Okay. Good. Makes sense? Okay. If the patient has a weak arm, you're going to undress the strong arm first and then dress the weak arm first. That just allows the garment to slide off and slide back on without a whole lot of movement there. Adjust clothing at the end for neatness and appearance. You're going to put your dirty items in the hamper, and the call light goes in the stronger hand. One of the things that really kind of makes me laugh with these skills is there's a lot of students, and I don't know why, but there's a lot of students who will just throw the gown on the floor and leave it there at the end, or put the privacy blanket on the floor and leave it there at the end, or put the towel from mouth care on the floor and just leave it there. They're adamant about, I mean, it's so prevalent. They had to create checkpoints against this, right? So remember, our rule is nothing goes on the floor. And we certainly can't leave it on the floor. That's a tripping hazard. It's also an infection control violation. I mean, there's so many things wrong with that. It's an unorderly environment. I mean, I could go on. Don't put anything on the floor. And if you do, definitely don't leave it there, right? So this test is not as hard as you think it is. Like, these steps aren't there to trip you up. They're there so that the patient has the best possible experience. And most of the checkpoints that you see are actually because students were doing something they shouldn't have been doing, so we had to write a checkpoint to keep them from doing it. Make sense? Kind of crazy. All right. We didn't do that one yet. All right. So this is where we're at right now. This is what we just reviewed. We know skill rules, the opening, glove rules, barrier, privacy blanket, linen rules, and the closing. We've mastered these. We're going to use these to create some new skills. And in fact, today we're going to learn 3 new principles. So by the end of today, we're going to be down to just 1 to learn. Okay? Not bad, right? Has it been too painful for everybody? I told you on day 1, just a week ago, that you were going to learn everything on that back wall. And you guys looked at all those words and your eyes went really big and you thought, oh my gosh, I have to memorize all of that? No, but you did learn it. Okay. So the way I teach is very intuitive. You guys remember me saying that on the first day? You're going to feel like it was easy when you end this class. And part of you is going to be like, well, do I really know what I need to know for the state exam? Because it just seemed too easy. You expect it to be harder. But you've learned a whole lot more than you think you have. You've learned, but I did it in a way that it just doesn't feel too much like learning. Good? Good. All right. So let's get into a new skill today. This is on page 116 of your skills book. This is hand and nail care. It is our first washing skill. We have several washing skills that we're going to learn how to do. This is the first one. They are all done the exact same way. So, of course, the first time we learn something, it takes some time to learn it because we got to learn some background stuff. And then we'll just apply those principles as we go. So if you look down the side here, you'll see all of the principles involved. They're all spelled out for us here. And man, this skill, a lot of principles. But we already know skill rules. We already know the opening. We already know glove rules, barrier, linen rules, and the closing. So really, even though this looks really complex, there's not a whole lot for us to learn. Okay, good. These are our skill-specific steps. I have a video for this. This is the short version. And then down here is our testing information. So somebody with your level of experience, which is none, should be able to do this skill in 11 minutes or less. We're going to read the care plan in just a minute, but I'm going to tell you you're washing one hand. One hand. And they're giving you 11 minutes to do that. This is a mini mani. That's all it is. I'll explain to you why we're doing it in just a minute, but it's a mini manicure. That's it. We're going to do this on a live testing student, which means one of you may be a patient for this. Remember during when they check you in for the test, you guys remember me saying that the RNs assess you? You guys remember me saying that? They look you over, they look at your shoes, they look at your body size, they look at what you're wearing. One of the things that they look at is your nails. If you have fake nails, acrylic nails, long nails, they're not going to use you as a patient for this. They're looking for somebody with natural nails. If you're a nail biter and you have no nails, you're not going to be a patient for this usually, unless they have no other options. So those evaluators, it takes them some time to, once they check you in, to match you up. Now, part of this is because, like, one of the skills that we're going to do is transfer from bed to wheelchair. For transfer, we want to pair you up with somebody your body size or smaller. So let's say that you have hand and nail care and you have transfer, right? She's your body size or smaller, so she would be a good match for you, right, for that skill. But you have acrylic nails, let's say, when you go to test, and she's got hand and nail care. So now I can't match you two up. So then I'm going to come over here and look at you. You're about the right body size for transfer, but one of your skills is to perform mouth care, and she just had some dental work done. So she can't be a patient for you. So now I'm like pulling my hair out, trying to figure out how we're going to match people up. Do you guys see how complex that can get when you have 8 people? Each of those have 3 skills. So there's some criteria that has to be met there. So it takes them 20 to 30 minutes to pair you up into groups. It's not random, guys, not random. But the whole point is actually to benefit you, because they're trying to give you the easiest possible testing experience. If you have to transfer somebody, they're not going to pick a 6 foot tall, 280 pound dude to be your patient, because that's not entry level. Make sense? Make sense? This was even more complex when we had to do weight. Weight used to be a skill, balance beam, weight. But because of sensitivity, we couldn't make the biggest people in the room be the ones that we were weighing, right? Because people are sensitive about their weight. So that became really difficult to try to handle. So thankfully, we don't have that skill anymore. That helps. So everybody understand how the skill is structured as far as who's going to be the patient? That patient will be positioned in a chair at the beginning of the skill. Charting is not required for the skill, so that just really makes it a lot easier. We're just going to do the skill, do our closing, and no charting required. All right, so our step-by-step instructions are located on page 117. At the top, we have our care plan, which we're going to look together in just a minute. We've got our step-by-step instructions. We've got some practice questions here to make sure that you understand the concept. And then down here are all of your supplies. And yes, I know there are a lot of supplies. I get it. Try to make them make sense, right? You have to wash something and you can't take the patient to the sink, so we got to bring the sink to the patient. That means you got to have something to hold water. You're going to have a couple washcloths and a towel, because whatever we wash, we rinse, whatever we rinse, we dry, right? So one washcloth to wash, one to rinse, one to dry. Oh, we haven't got there yet. I'm sorry. I have to tell you about that. You have to have soap to wash with. You're going to have some lotion after you wash. And we're going to do, remember I said it's a mini mani, so we have to have some way of cleaning the nails and filing them. So try to make it make sense when you're memorizing these supplies. Good? Good. All right. I have flashcards. You guys all know this. The flashcards have supplies for every single skill. These are all the supplies listed here. So my flashcards go with my book exactly. There will never be a mismatch there. And for you guys, they're $14.99. Okay. So let's look at this care plan. The people online, those people, they have to pay, I think it's $24.99 for the flashcards. You guys are getting a deal.
How do we buy them though? $14.99.
Jake,
Oh, okay.
just tell him.
Jake charged me $19.99 today.
Oh, Jake.
My apologies. I owe you money back.
Yep, sorry. We need a price list here. Oh, Jake, we've got 0 viewers, so something is disconnected.
No, it's the feed from StreamYard is glitching. Even on YouTube, it's telling me 0, but there are people in the comments.
Okay.
Commenting.
Yeah. All right, we got a disconnect there. Okay. So here's our, we'll get you your refund. Here is our care plan for this particular skill. It says provide hand and nail care to one hand. The patient is sitting in a chair at the bedside and can move as directed. Okay. So this is a pretty easy care plan, right? Provide hand and nail care to one hand. Your patient can do what you ask them to do. They just can't get up and go to the sink, right? We're going to bring that to them. But it's a pretty easy care plan. Now, let me explain to you a little bit about why we're doing this particular skill. Nail clippers, the things we use to clip our nails, those are not allowed to be used by CNAs. We don't use those. We don't trim nails anywhere, not fingernails, not toenails. We don't use nail clippers. But if you file nails on a regular basis, you keep them short enough, you never have to trim them. So filing carries less risk to the patient than trimming. Anybody ever trim babies' nails? Okay. If you've ever trimmed a baby's nails, now baby's nails are super teeny tiny, they're really, really flexible, but we still end up usually clipping their skin. Okay, on the corners. We just do. Now that's horrible. We always feel bad and the baby starts to cry and then we start to cry and it becomes a whole big thing, right? We feel horrible. But the problem is that nail trimmers tend to trim more than just nails. And that now creates a new body opening for pathogens to get into. Now, if your patient has diabetes, that becomes even more dangerous because we have delayed healing. So it's an unacceptable risk. We do not use nail clippers, which is why we have hand and nail care. If we soak the hand, wash the hand, rinse the hand, dry the hand, lotion the hand and we file the nails and clean under them, we never have to trim them. It's preventative maintenance rather than corrective action. Make sense? Okay. So that's why we're doing hand and nail care. But in order to know, in order to learn hand and nail care, we have to know how. So we're going to cover these two principles. Washing rules is going to come first. This is our first principle that we're going to be learning for this skill. And as you can see, there's several steps we have to learn, and they're going to apply to 5 skills. So out of the 20 we're learning, a quarter of the skills are washing skills. So we're going to use this quite a bit. But we always follow the same steps every time. So we're going to learn it once and apply it here, 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 and here. Good? So let's learn the steps. In order to understand these particular steps, page 113 has our notes for this topic. We have to think about how we bathe, right? You get into the shower, you turn the water on, make sure the temperature is appropriate. You step in and you get wet. Then you apply soap, however you do that, washcloth, loofah, scrubby, however you do that, but you apply soap. Then you rinse the soap off. Then you get out and get dried, right? Those are very predictable steps. Every 4-year-old knows this process. For some reason, when we do this on other people, we tend to forget one of these steps. I don't know why, but you will. You will forget one of these steps. Not might, you will. So I've got a way to help you remember where you're at in this sequence, okay? So when we are bathing ourselves, we check the water, make sure it's okay, and then we get in and get wet. And whatever we wash, we rinse. Now, I want you to remember that. Whatever I wash, I rinse. Because when you're over here working on a body or working on a hand and you're washing, you probably, because your mind is going in a lot of different directions, you may be having a conversation with the patient, whatever, you may forget to rinse. When you're doing a partial bed bath, you will forget to dry the face. You will. You'll forget. So I want you in your mind, as you're washing things, to think to yourselves, whatever I wash, I rinse. That tells you where you are in your step. Whatever I wash, now I have to rinse. So you get your rinsing washcloth. And you rinse. And as you're rinsing, your brain needs to say, whatever I rinse, I dry. Okay, if you do that, as you're doing the steps, whatever I wash, I rinse, whatever I rinse, I dry. If you do that as you're doing the steps, you will never forget a step. Now, I had a student test not too long ago, maybe close to a year ago now. And she sat over there and kind of rolled her eyes because, you know, this is so first grade stuff, right? Yeah, whatever. And she went and tested, and she got partial bed bath. And she did not, whatever I wash, I rinse, whatever I rinse, I dry. She got all done with the test or with the skill. She said, my skill is done. Remember, after you say your skill is done, you cannot make a correction. And in her mind, after she said, my skill is done, I actually think she was into her second or her next skill, whatever that was. She realized that she did not rinse the soap off of the mannequin. There was nothing that she could do at that point. Nothing she could do. And in reality, if it had been a real patient that had soap on their skin that was allowed to dry, there's not much you can do after the fact. That patient is now going to be itchy. Right? So these steps exist because it has a consequence on the patient. Does that make sense? She actually sent me an email and said, hey, listen, I should have used it. If my brain had done whatever I wash, I rinse, whatever I rinse, I dry, I wouldn't have missed that step.
Did you say instead you were rolling your eyes?
No, I just said, well, this is a great learning opportunity because in a clinical setting, this does matter. It matters to the patient. So it's just a great learning opportunity. And now moving forward, you probably won't forget to rinse where it really counts. So even though it was a mistake on the test, you can overcome that. That's okay. You've learned a lesson that you'll take with you on your nursing journey. And that's probably more important. Good? Makes sense? Everything is a learning opportunity, guys. Everything. All right. So basins, because we have to rinse, right? If we're in the shower, then we're wetting, washing, and rinsing all in the same place. That's fine in the shower. You wouldn't just jump out of the shower with soap on your skin. It wouldn't make any sense. You wouldn't even think about doing that. Your body's on autopilot, just does what it needs to do. But the problem is that we're not in a shower. We're at a table with a basin of water. So because we have to rinse, that means that we can't put soap in that basin because we have to rinse. Does that make sense? If you put soap in the water, you can't use that water to rinse. Now, some of you are going to say, well, I'll just go get another basin. And that's fine. You can. You can go get another basin and have one to wash and one to rinse, but you don't need to. If you have two basins, it's twice as much cleaning they have to do at the end. That's more work for you. But it's also twice as much cost for the patient. Anybody ever been a patient at a hospital? Did you ever get a bill? Healthcare is cheap, isn't it? Healthcare is crazy expensive. Crazy expensive. And the thing is that bill that you get from the hospital is just like a total charge. They don't like break it down for you and tell you everything that you're paying for unless you ask. And if you ask, hey, I want an itemized bill, you'll see everything that they used on you. Everything from toothbrushes to basins to everything. Everything. The food that you ate, everything is on this list. The basins are about $38 a piece. So you just made a $38 decision for your patient without asking them. You made a decision. You gave them a bill that they now have to pay with no input. This is the equivalent of going to a restaurant, sitting down, no menu. The chef is going to decide what you eat tonight. And they don't tell you how much it's going to cost. So you don't get to choose your food. And when you get the bill, you have no idea what it's going to be, but you have to pay it before you leave. Would you go back to that restaurant? We do this in healthcare all the time. It's important that you understand that the decisions you make about supplies are going to show up on the patient's bill. And that's not fair to them. Use what you need, but don't use extra if you don't need it. It's like there are several in the CNA forums that I'm on online. There are several CNAs that throw bedpans away after every use because they don't want to clean them. Yeah, they just throw the bedpans away. Absolutely. Absolutely. That's not appropriate. We don't do that. We clean the bedpans. You throw your toilet away every time you use it? Do you have a new toilet installed every single day? 3-4 times a day? I mean, it's ridiculous. But those bedpans cost money. CNAs don't care. They're not paying for it. But they are. Because the more money that the facility gets shafted on, right? Because these patients aren't going to pay all these bills. And especially if they're smart patients, because they asked for that itemized bill and they see 12 bedpans and they say, I'm not paying for 12 bedpans. I'm only paying for one. So that facility had to eat those other 11 bedpans. They had to eat that cost. What do you think that's going to do to your raises and your pay scales? Yeah. So those CNAs that are using supplies that aren't going to be reimbursed are costing you in your hourly wages. Good? Make sense? Okay. I didn't know any of that when I was young. I had no idea. And when I went into purchasing right out of high school and got that purchasing job, that's when I learned that every single item that is used on you gets billed. And I was the one that set the prices. So I know how much this stuff is marked up. Okay, don't do that to your patient. All right, so because we have to wash and rinse, we want to make sure that we don't add soap to our water. We don't need to. We want to keep that water clean for rinsing. You wet your washcloth and you apply the soap to the washcloth. And then you don't put soapy washcloths back in the basin. That keeps your water clean for rinsing. Easy, right? Easy. All right. So we get a basin and we have to go get water in the basin. Now, we know that we've done our opening. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? I'm going to go wash my hand, close your curtain, wash my hands, get my supplies, and I do all that. And now I've got my basin and I'm going to go get some water in it. Can my hands touch that faucet?
You have to turn it on and then you have to wash your hands before you touch the basin again.
Okay, so because the faucet is not clean and my hands are. All I've touched are clean supplies, right? So what could we use between our clean hands and the dirty faucet? Paper towel, so we don't have to wash our hands again. Yeah, absolutely. So we're going to use that paper towel. So we get our basin, we go over to the sink, and we turn the faucet on with a paper towel. Now, it should be warm, not hot, not cold, just warm. Okay. So we're going to check it with the inside of our wrist. This is the most accurate temperature sensation you have. Don't use the back of your hand. You've got a lot of tendons and not as many nerves there. It's the inside of your wrist you want to use. Warm, not hot, not cold. But just because I think it's comfortable does not mean my patient is going to agree. And again, we have different temperature perceptions. We talked about this earlier with privacy blanket. You guys remember my temperature perception of my patient's not the same? This gets even worse. This concept gets even worse. We want our patient to check our water temperature. Okay. We want the patient to check the water temperature, and we're just going to hand it out to the patient. Is this good? If the patient says, yes, it's fine, cool, you can proceed. If they say, no, it's too hot or too cold, we're going to stop and correct. Don't argue with your patient. Do not argue with your patient. This happened. I was working in a long-term care center. I was at the nurse's station, which is kind of in the middle. And shower room is way down this hallway to my right, way down toward about 3/4 of the way down the hallway on the right. I hear screaming from the shower room, blood-curdling screams from the shower room. I get up and go running because I'm sure somebody has fallen at this point, right? Something is definitely wrong. I go running down the hallway, run into the shower room, and my glasses immediately fog up because steam, right? I can't see a thing. I'm kind of feeling my way. What's going on? What's going on? What's happening in here? And the CNA is saying, she won't let me, she keeps fighting me. She won't let me wash her, and just like frantic. And the patient is screaming. I mean, it was like bedlam. So finally, I whip my glasses off so I can see what's happening. And there's so much steam in the room. And the patient is just hitting for everything she's worth, kicking, she's in a shower chair, trying to get away from this CNA in the shower. And the CNA is trying to push her back under the water. And I'm like, hold up. that water is too hot. I go over and slam off the water, hit the thing to slam the water off, and the patient is just sobbing. Her skin is red. And the CNA says, it wasn't that hot. Okay, I can barely see you for the steam. It is definitely too hot, but regardless, it doesn't matter what you think. If it was cold and the patient said it was too hot, you listen to them. I don't care what you think about the water. You aren't the one under it. Listen to your patients. This patient, it was heartbreaking. Her family actually pulled her out of there. Yeah, that wasn't the first issue that had happened. But the problem is that help isn't help if it doesn't help. We can't lose sight of why we're there. This isn't just a routine for you guys. This isn't just a clock in and do my job and go home. These are people. These are people that have no other options. If she could wash herself, she would be at home washing herself. But she can't, so she has to rely on us. She's not here for convenience. She's here because she needs to be. And we have to respect that. So when I tell you to make sure that the patient has okayed that water temperature, this is probably the most important step of what we do with bathing. Because your opinion means nothing. Now, there's a physiological reason for this. Physiological. And let's talk about this. As we age, your layers of skin shrink. So we have, when we're young, nice, thick, plump layers. Big, meaty, juicy layers. As we get into middle age, you start to see those layers breaking down a little bit. They get thinner, and this especially happens in our extremities. As we approach older age, those layers are super thin, and you can actually see the changes visually on the outside. Have you ever seen an older person's hands? They look like this. Look at your hands. Your hands probably do not look like this. Yeah, mine are too. Mine are too. So that means that there is a change that occurs. A physical change, one we can see. So what does that mean? What does it mean? Why do I care about this? Well, I care because this layer right here, this fat layer, is the one that tends to go away. It gets resorbed. And you end up with basically skin over bone and tendon, and you can actually see the blood vessels under the skin. Now, this is going to affect your patient's temperature perception in a very big way. That layer of fat has a very specific job. It holds in body heat and it blocks out external temperatures. So think about a deep sea diver, okay? The ocean, deep sea, very cold. They have to put on a wetsuit because otherwise that cold ocean will reduce their body temperature too quickly. Wetsuits are there to block out the cold and keep in your body heat, right? That's exactly what this layer of fat does. Now, as we age, we lose that layer of fat. So why do we care? Normal body temperature is about 98.6. It's actually a range, 97.6 and 99.6, but we kind of distill it down to about 98.6. Okay, that's normal body temperature. Everybody good with that? Okay. All right. There is a principle. Room temperature always wins. Always. Room temperature always wins. And I'm going to prove it to you. This is a physics principle. If I'm baking a pie and that pie is in the oven at 325 degrees and I pull that pie out, can I eat it right away? No, because the pie is 325 degrees. It is very, very hot. I put it on the top of the stove and I have to let it cool. Now, if I leave that pie there for long enough, that pie will always cool to room temperature. Now, room temperature is right around 75, we'll just call it 75. It depends on what room you're in, whether there's AC or heat. But right around, let's just say 75 is where we're pretty comfortable. Good? So that pie cooled down to about 75 degrees. It'll never go colder than that. Never. It won't stay hot on its own. Room temperature always wins. Now, what goes well with pie? Ice cream. So ice cream in the freezer is about 0 degrees. I pull it out. When I pull it out, it's super cold. I set it on the counter, and if I leave it there, well, that ice cream stays 0 degrees. No, it warms up. And do you know what it warms up to? Room temperature. Room temperature always wins. Always. You guys got that principle? Okay. That's important because our bodies have to maintain 98.6 degrees. And I just told you room temperature always wins. So how do we stay hotter than room temperature if room temperature always wins? Well, that means that we have to have an active process to induce heat. We have to create heat inside us. And we do that through burning calories. That's why that word, that's why we use the word burning. You eat so your body has fuel to produce heat to maintain this temperature. Now, this is so critical. I mean, this is really, really critical. You guys don't realize just how delicate this balance is. You have to maintain 98.6 degrees. You can go a little bit lower, but not too much. If you go below 95, that's hypothermia. 95. That's not very far from here. 95, hypothermia. Below 93, you are dead. Dead. Cannot sustain life. So 93 is still way far away from 75 room temp. This is critical for us. We have to produce enough heat to keep our bodies above 95 degrees or we die. And your body is constantly fighting room temperature. You guys understand that? That's a lot of work for your body. Oh my gosh. That's a lot of work to keep you high enough to live. So your body wraps you in a sheet of fat, like a wetsuit, and that fat holds in the body heat that your body creates. Keeps it from radiating away. It also blocks out that room temperature and keeps it from affecting you quite so badly. So that layer of fat, super important. But I just told you that as we age, that layer of fat decreases. This is not cooperating. So if you looked at a cross-section of your skin, you have muscle, fat, skin, tissue, epithelial, and the supporting structures. So this is kind of a cross-section of your skin. That layer of fat is trying to keep body heat in and outside temperatures out. It's doing two jobs. The problem is that when we lose that layer of fat, it is going to affect your patience in a very real way. And this happens as we age. Have you ever walked into grandma's house and you're like, oh my gosh, grandma, it is so hot in here. It's hot. Well, remember, they don't have that layer of fat. That layer of fat's starting to dissipate. So by keeping their environment warmer, they don't have to fight against room temperature as hard, right? It makes their body work a little less, which is why older individuals prefer warmer environments and they all move to Florida. You'll hear older people say all the time, I can't handle the cold anymore. I can't live up north. Well, that's a real thing. It's a real thing. It's not about shoveling snow. It's about their body's ability to compensate for the temperature changes. Now, unfortunately, we have older people who are unable to regulate their temperature very well and have to fight against room temperature, and we put them in a clinical facility and we keep the temperature cold because we don't like pathogens. So your patients are always going to feel cold, colder than you think they're feeling. Does that make sense? So you might put a blanket on them, and a few minutes later they call and ask for another one. You think, oh, they're crazy, they're nuts, something wrong with them. No, it's because they don't have the layer of fat that you do. Make sense? Good. All right. So the way that I perceive temperature, water temperature, is going to be through a layer of fat that my patient does not have. So when I put my hand in the water and I feel it, it might feel perfectly okay to me. Perfectly fine. Lukewarm. Barely anything. And I take it to the patient and they put their hand in it and they say, oh no, that's too hot. I'm not going to argue with that patient. No, it's not. I just checked it. It's fine. Put your hand in there. To them, that temperature is unacceptable. I am going to say, oh, I'm so sorry. Let me cool it down for you. One moment, I'll be right back. I'm going to take care of the problem, not argue with the patient. Good? Good. Now, for the exam, this matters. Because if you were doing a washing skill and you go get water and you check it with the inside of your wrist, that evaluator is going to put their fingers in that water and they are going to check it. And if that water is too hot, it doesn't matter what the patient says for the test. If that water feels too hot, you won't get that checkpoint. If that water feels ice cold, you're not going to get that checkpoint. So this matters. This is real. They are really going to check this. It should feel warm, not hot, not cold, just warm. And then once we have checked it, we're going to take it over to our patient and we're going to ask them, can you please check the water? And we're going to listen to them. Now for the test, they're going to say it's fine. Because when you're a patient for the test, you get a script. Follow the script. Okay. Good. Questions? Okay. And then we get to our order. We've already gone over this. Whatever we wash, we rinse. Whatever we rinse, we dry. These are graded checkpoints. So you have to hit all three of them. So remember what I said earlier about the student who forgot to rinse? You guys remember that? Okay, this is the checkpoint. Okay, clean, right? Soap, rinse, soap, and then dry is on a separate line. So cleaning and rinsing all on one line. So because she did not rinse, she did not get that checkpoint. Cleaning didn't matter because cleaning and rinsing were on the same line. You have to get all of these words for it to count. All of these words for it to count, not just some. Good? Make sense? Okay. All right, this is what your skin looks like if you forget to rinse. And forgetting to rinse is the most common problem with washing, but this is under magnification. That's what soap looks like when it dries on your skin. It makes you itchy, dries out the skin. It can actually cause skin openings. That's a problem for us. So please make sure you're rinsing. All right, to water if we are slow. If that water gets cold, change the water. If you accidentally put soapy washcloths back in that water, you can't use it to rinse with, change the water. So if it gets cold or if it gets soapy, address it. Don't ignore it. Dry surfaces should remain dry. This is why we use a barrier on the table. Keeps our table dry. And then at the end of the skill, we're going to put some lotion on the patient's hand. So anytime we're going to use lotion, we warm it up in our hands. Don't squirt cold lotion directly on your patient. That's mean. Don't do that. Warm it up in your hands first, then apply the lotion, and then we'll wipe off the excess lotion. So these are the rules for washing, okay? We're going to use these rules for hand and nail care. We're also going to use them for foot care, partial bed bath, peri-care, and catheter care, these same rules. But if we have a basin of water that we're using for any skill, we have to know how to clean that basin at the end of the skill. Now, for the test, don't get too wrapped up in this, okay? For the test, it's only going to ask you to rinse it, dry it, and store it. That's it. That's all you've got to do for the test. Rinse it, dry it, put it away. Make sure you dry it well, because remember, warm, dark, moist, wet, right? So if we put a basin that still has moisture in that drawer, it is warm in there, it is dark in there, and now we have moisture. So we end up with pathogens. So please make sure you're drying well. Make sense? Good. But I've got a whole process on basin cleaning. So anytime we're using any sort of a basin is a container that holds liquid. If we're going to be using a basin, we have to clean it appropriately. This takes up about half of our skills is going to apply basin cleaning. So I've got a process here that we're going to learn. Notes are on page 91. Remember, for the test, rinse it, dry it, store it. That's all you really need to know. But I'm going to take you a step further, because in some settings, you need to disinfect your basins. If you're working with a chemotherapy patient, you guys know what chemotherapy does? Doesn't just kill cancer, it kills your immune system, your entire immune system. That means, so we're not just killing the bad guys, we're killing all the armies, everything. We're starting over, fresh slate. That's a problem, because that leaves your patient open to invasion. So if we have a chemotherapy patient, we probably want everything we use on them to be as clean as possible, and disinfection is going to be a part of that. If you're working with an HIV positive patient, we want to make sure that we're not introducing new pathogens because their immune system is compromised. Good, makes sense? So several situations where I, as the nurse, am going to have on the care plan that all basins need to be disinfected after use. So you need to know how to disinfect. You don't have to use this for the test. For the test, they're not going to ask you to disinfect. We rinse it, we dry it, we store it. But we're going to use a process that allows for that disinfection step should we need to use it. Good? Okay. So what that means is that we are going to dump our basin wherever it would normally go. So if it's water, water goes in the sink. Water goes in the sink. If it's urine, does urine go in the sink? Goes in the toilet. If it's emesis or vomit, where does toilet, right? So we're going to put whatever's in the basin where it normally goes. Water can go in the sink. We don't put dirty washcloths in the water, right? Remember that? We don't put soapy washcloths back in our water. So the basins just hold water. Good? Makes sense? Okay. All right. So we're going to dump it where it normally goes. Then we're going to rinse the basin. And we rinse the basin usually in the sink, right? Because that's where we have running water. Now, there is an exception to that we'll talk about when we get to bedpan on class 7. But for the most part, we're just going to use the sink and we're going to rinse our basin. But that rinse water has to go wherever the basin contents went. So if you are working with urine, okay, and you're rinsing your bedpan, please don't put the rinse water in the sink. Because as you're rinsing it, you're going to have some urine that goes in the toilet. Make sense? So we dump it, we rinse it, and we put the rinse water wherever the contents went. Now, basins are only used by one patient. When you go to the hospital, you get an admission kit, has your basins in it, that is yours. We're not sharing your emesis basin with her. We're not sharing your bedpan with her. We're not sharing your wash basin with her. They're yours and yours alone. Nobody else uses them. So rinsing, drying, storing, perfectly okay for most everyday situations. You're the only person sitting on that bedpan. We're going to rinse it. We're going to dry it. We're going to put it away for the next use. Good? Questions? Okay. But there are some situations where we are going to have to disinfect. So for the test, we rinse it, we dry it, we store it, but we're going to do it in a way that allows for this disinfection to happen. So I dumped my basin, I rinsed my basin, and I dumped it wherever my stuff went. I have dirty gloves on. It's important that we understand that. Either my hands are dirty because I haven't been washed yet, or I have dirty gloves on, and chances are you have dirty gloves on. I cannot hold this basin with dirty gloves or dirty hands and disinfect it at the same time. I can't touch this basin as I'm disinfecting it. So I dump it, I rinse it, I dump it, and I set it down in the sink. Hands off. And then I spray it. Okay. So I set the basin down in the sink and I spray it. Now I have to pick it up to dry it, but I have dirty gloves or dirty hands. I can't pick up this now clean basin, this disinfected basin. So what could I use between my dirty hands or dirty gloves and the disinfected basin? A paper towel. Absolutely. So I'm going to use a paper towel to pick it up because we can't touch it with our dirty gloves. I'm going to use a paper towel to pick it up. I'm going to use a paper towel to dry the inside. Remember I said that we have to dry it really well? So I'm going to use a different paper towel to dry the outside because that inside paper towel is wet. So I need a different paper towel to dry the outside. Good? Then I'm going to go grab my supplies with another paper towel, put them in my basin, and open the drawer with that paper towel. Because remember, my hands are not clean. So I don't want to touch the outside of that drawer. I don't want to touch the toothpaste or the soap or the lotion bottle or anything else with those dirty hands or dirty gloves. So we use that paper towel for everything. To get our supplies, put them in the basin, to open up our drawer with. We're going to put our basin and supplies in and close the drawer with that paper towel and then throw that paper towel away. Okay? All basins are going to be cleaned the same way. You're going to see this 9 times. If you didn't get it this time, you will get it in one of those 9 times. But to recap, we dump the basin, rinse the basin, dump the basin, set it down. For the test, we skip the spray, but we still use a paper towel to pick it up, paper towel to dry the inside, throw that away, paper towel to dry the outside, throw that away. One more for the supplies in the drawer. That's how we do basin cleaning. Good? Questions so far?
Do we use different basin for like different purposes?
Nope, the bath basin is going to be used for everything bathing. And that's okay because all it's going to do is hold water. So every basin that we use is going to be cleaned the same way. So now we know these 2 principles. We only have 1 left. That's it. 1 principle left to learn. We're going to use all of these principles to create some skills though. So now let's look at our skill-specific steps for this skill. This is our checklist for this skill, hand and nail care. Okay, this is our checklist. Now I want you to pay attention Everything that is colored on here is a principle that we've already learned. So doing our opening gets all of these check marks. Using glove or evaluating if we need gloves is going to get this check mark. Linen rules is going to get these check marks. Good so far? Washing rules are going to get, these check marks. Basin cleaning is going to get that check mark. The closing are going to get these check marks. So we haven't even got to the skill yet, and we've got almost 3/4 of our check marks filled in already before we ever get to the actual skill. Do you guys see how using these building blocks can help you learn the skills?
So for, if we look at the skill, I think there's one with the bedpan, right?
Yes.
So how would we go about on, like, if we got that, how would we go about cleaning the bedpan?
We're going to talk about that in detail in class 7. 7 is all on toileting. So bedpan, catheter care, and drainage bag. We'll go into that in detail. All right, so for this particular skill, we're going to soak our hand in the basin. That's a graded checkpoint. And then we're going to take that hand out and put it on a towel next to the basin. As that hand is there on that towel, we're going to wash the hand. We're going to do that by getting our washcloth wet, wringing it out really well, no drippy wet washcloths, and we're going to put soap on that washcloth. And then we're going to wash all surfaces while that hand rests on that towel. Wash the hand. And once we're done washing the hand, we can put that washcloth aside on our barrier, never on the floor. And we're going to take that hand and gently, we're going to pick it up and put it in the basin to rinse. Then we're going to take it out of the basin gently and put it back on that towel to dry. Whatever we wash, we rinse. Whatever we rinse, we dry.
But wouldn't the hand still have soap on it?
Right, and we're not going to use, we're done after that because we're only doing one hand. Our care plan said one hand, so perfectly okay. We're not going to be using that water after. And it's okay to have a little bit of soap. I mean, dilution ratio, you still have some water in there to rinse with, right? We're not putting the soap directly in the water, which is what they want us to avoid. Little bit of soap from the hand in the rinsing water is not a big deal. But for this skill, we're only washing one hand. So once we're done with the rinsing, we're done with the basin. Good? Make sense?
It makes sense, but why are, you're saying that this is the skill that we could possibly get on our state exam,
Yes.
but in reality, if we're ever, when we're working.
Okay, why would we only be doing one hand? Is that what you're asking?
Yeah.
Okay. Okay. Great question. And the answer is you don't need to know why. I'm going to explain why. Hold on. I'm going to help you with that. But in reality, you don't need to know why. We follow the care plan. We don't know what the reasoning is. We don't care what the reasoning is. But
I get that.
what if the patient has an incision on one hand?
I get that.
What if the patient has a cast on one hand? What if the hand has been amputated and is no longer there? What if the hand has shingles infection and open sores on that hand? There's a lot of reasons why the care plan may only say to wash one hand. But in reality, out there in a clinical setting, going to be very, very rare that you're only washing one hand. In most cases, you're going to wash two. So here's your real question. I know where you're going with this. Okay, so here's your real question. All right, so if I've washed and rinsed one hand, I've got soap in that water, what do I do with the second hand? And that's your real question. And the answer is depends. Is it really soapy? If it's really soapy, go change the water. If it's not so soapy, because you're not using a lot of soap here, guys. You're putting a couple of sprays on a washcloth, and it's spray soap designed not to suds up real well. You're putting some soap on a washcloth, you're washing, and then you're putting that hand in the basin. It's going to dilute out the soap. We can use that hand again, or that basin again. Not usually a problem. But the biggest thing is use your eyes. If there's lots of soap, change the water. Yeah. You could also do them at the same time. No problem with that either. Take both hands, put them in the basin, get them wet, take them out, wash them, put them both in to rinse. Perfectly okay. Okay, so either way is fine. But that's your real question. Okay, wait a minute. Why would we only do one, and what happens when we have to do two? And you can do them both at the same time. Same thing with foot care. This question comes up a lot more in foot care. With foot care, if you're doing 2 feet for the test, we only do one. But if you're doing 2 feet and both feet will fit in the basin, do them both at the same time, no problem. Put the feet in to soak, take them out to wash, put them in to rinse, take them out to dry, no worries. A lot of times your patient's feet will not fit in the basin at the same time. Basins aren't that big, and some of these feet are. Okay, so in that case, you do one and then you do the other. And if the water in between gets cold or soapy, just change it. That's why one of our rules for washing is if the water gets cold or soapy, change it. Good? Questions? Questions? Okay. When the hand is out of the basin, it should be laid on a towel. A towel is a softer surface, not directly on the hard table. Then we're going to clean under the nails. So we put the hand in the basin to soak. We took it out to wash. We put it in to rinse. We took it out to dry. Once your hand is dry, we're going to clean under the nails with an orange stick. Now, this is an orange stick. I'll send these around. This is an orange stick. It has a slanted edge and a pointy edge. So you can see that here, a slanted edge and a pointy edge. We use the slanted edge and we slide it right under the white part of the nail, not too far. Okay, and we circle it across under the nail, and then we wipe that gunk off on the towel. Don't take gunk from this nail and put it under this one. So we put it under, circle it around, wipe. Put it under, circle it around, wipe. And we go through all nails. Then once your hand, the nails on that hand are clean, then we're going to file the rough edges with an emery board. Now, to do that, to file the rough edges, we're not going to file the way you do. So if I've got a nail that needs to be filed, I'll take this emery board and I'll go really fast along the edge of the nail. That doesn't work when we have elderly people and people with long-term chronic conditions, because one of the things that's affected is the brittleness of the nail. When nails become brittle because of collagen synthesis, the nails themselves, brittle nails, will split right up the middle as you go back and forth along the edge of the nail. Because what you're doing is you're pulling and pushing that nail along a longitudinal axis. So it'll split right up the middle, and the nail will eventually fall off. It's horrifically painful. It takes about a year to grow back. This is not something we want to do to our patients. So when we are filing, we file in one direction only. Sorry, I forgot to advance. On break here, we will, for those of you who are attending virtually, I'm so sorry. And those of you who are going to watch the replays of this, on break, we're going to reload everything. So hopefully it'll go a little bit better. We'll reset. So let me see here. Support the hand and wrist at all times. We talked about that. Oh.
Is it not forwarding?
Yeah, I don't know. I think it's jumpy. There's a lag, so I'm going too fast. Okay. So when you're filing the nails, we go in one direction only toward the center. So if I'm going to file this nail, instead of going really fast across the edge of the nail, I just go in one direction toward the center. And then you can knock down that point by going across. Good? Good. All right. So after you have soaked the hand, washed the hand, rinsed the hand, dried the hand, cleaned under the nails, filed the rough edges, now we're going to apply a little lotion. So I'm going to take the lotion, squirt it in my hand just a little bit, not a lot, rub it in to warm it up, and then apply that lotion to all surfaces And then we take the towel and we take off the excess. You wipe off the excess. Because if we put lotion on that hand and they go pick up a cup of coffee in a few minutes, that coffee is going to slip right out of their hand because it's that all of the lotion does not absorb. So we rub it in and then we wipe off the excess. So it depends. It depends. If our patient has a scratch on that hand, do we need gloves? If our patient has a lot of body fluids or body substances under the nails, do we need gloves? So this is something you can kind of assess by looking at, right? So if there's body fluids, if there's any sort of skin openings, then yes, you need gloves. If you have a skin opening, do you need gloves? Yes. But if the hand is mine, okay, I have no, you're not going to be up here. This is a, by the way, this is a scratch. My dog got me here, got me here. Got a rambunctious dog. So if you're going to do hand and nail care on me, you're not anywhere near this, so you don't need gloves, right? I have no skin openings. Everything is fine. My nails are clean. You don't need gloves. Okay, if you're not sure, if there's a maybe there, and we kind of covered that with glove rules, if there's a maybe, you can wear gloves. Now, here's what happens, though, during the state exam that you need to be aware of. If it's very clear that gloves are not indicated and you decide to wear them all the time, if you just go in and you just wear gloves all the time, at some point, those evaluators are going to tell you, you don't need gloves for this. Do not wear gloves for this. You don't need them. Because remember that supplies cost money. And if you're using gloves and gloves and gloves and you're changing your gloves 3 times during the skill and gloves, that's a cost that you aren't bearing, but the facility is, right? And this is the same thing in a clinical setting. When you are using gloves unnecessarily, that's a cost to the facility. That will show up in a paycheck. You won't get paid as much. They're not going to give you raises. So it is important as healthcare workers that we understand the economics of what we do as well as the physical structure of what we do. If we just start making decisions for somebody else to pay, that may impact our pay scale. Does that make sense? So yes, you can. You can absolutely wear gloves if you feel that they're necessary. Sure. But if you're just wearing gloves with no real awareness of when they're appropriate, that evaluator is going to call you out on it. Absolutely. They will. And that really unsettles students because now they're like, oh my gosh, that was my glove, process. I just wear gloves for everything. Now what do I do? Because now you don't know what you can touch and what you can't touch. And it really kind of derails your whole thing. This is why the test is structured. I told you the test is very scientific, right? You get a care plan with 3 skills, and you have to do those skills in order, right? Those evaluators know which of those skills are a yes on gloves, a no on gloves, and a maybe on gloves. This is what they do all day long. So if you are wearing gloves all the time, they know that you don't understand infection control. And now they're going to grade you even harder on what you're touching. Because ultimately, that's going to put our patients at risk. Does that make sense?
I don't want to throw anything off, but my biggest concern with this new career that I'm going to join is I have a huge bad habit of biting my nails and the sores that I get from biting my nails. So I haven't figured out how I'm going to do that because I know I can't have my acrylics either.
Well, a lot of places will allow acrylics. That's a great interview question. That's fine. And especially if you're using acrylics to prevent nail biting. I mean, that's, I would work very hard to get rid of a nail biting habit if you're going to work in healthcare, because when you're stressed, and guys, working in healthcare is a high stress job, right? So when you're on the job and you're stressed, you're going to go to whatever your coping mechanism is. And if it's nail biting, your hands will end up in your mouth in a clinical setting, and that is not a good deal. So I would work really, really hard on that. Yes, yep.
I mean,
Yeah.
I am an older person here, and I've been doing it for pretty much my whole life.
Yeah, I would work on some strategies there for sure, because and more to protect you. And that's, I'm not really talking so much about the test. And you can wear acrylics for the test. That's fine. That there's no problem with that. And certainly if you have open sores on your hand, you know, you definitely need to wear some gloves. And I probably would say that during the test. I've got some open sores on my hands, so I'm going to wear gloves for every skill. And that's fine. That kind of covers you. It shows that you are aware of infection control. My concern is not for the test with your situation. My concern is when you're working, because if you have open sores, that's another port of entry, right, from biting. If you bring your hands up to your face in a clinical setting, that's definitely a risk. So I would really maybe put a rubber band around your hand and snap it when you feel like you want to bite your nails. I mean, there's a lot of stop the habit processes you can find online. Find the one that works for you, because that's a very, very dangerous habit in healthcare. So I'm more concerned about you and your well-being in that situation. So, all right. So as we're moving, we're going to support that arm at all times. We're going to wipe off the excess lotion. And now we know all of the principles that govern this particular skill. Okay, so we're going to follow the care plan. We're going to do our opening. We're going to evaluate if we need gloves. We just talked about, we'll use a barrier on the table. We're going to employ linen rules, washing rules. We're going to clean our basin. We're going to follow these steps that we just talked about for hand and nail care, and we're going to do our closing. So we're going to put all of that together and look at our checklist and see how we're going to check all of these things off using these principles. So we're going to follow the care plan, which is going to get us those check marks. We're going to do the opening, which will get us those check marks. We're going to use a barrier. This thing is so laggy. We're going to use a barrier, which will get us that check mark. We're going to evaluate if we need gloves, which will give us those check marks. We're going to use linen rules, which will get us that check mark. We're going to use washing rules, which will get us those check marks. We're going to clean our basin, which will get us that check mark. And we're going to do our skill-specific steps for those marks. And then finally, we will do our closing, which will give us maybe those check marks. Very glitchy. Sorry, guys. So any questions on how we use these principles to build skills?
My apologies.
It's okay. Everybody understand how we're using these principles to get these? All right. So we are going to remember that this care plan is only for this patient. This one will have a different care plan. This one we might be doing 2 hands. This one will have a different care plan. She takes care of her own, right? She goes to the sink. She washes her own hands. Not a problem for us. We may have a different care plan for this lady. Maybe she's got some sort of a psoriasis condition and needs hand and nail care a little more frequently. So everybody's going to have a different care plan based on the needs of that patient. This one for the test is only for this patient. That's it. So as CNAs, we get a care plan. And what do? Follow. We don't need to know why we're only doing 1 hand. We don't need to know what the patient has. We don't need to know, you know, all of that. That's nursing stuff. We just need the instructions and to follow them. Good. Anybody here cook or bake? Yeah. So there's a difference between being a cook and being a chef. There's a difference, right? a cook, I can get a recipe and follow it, and it's pretty much guaranteed that the stuff is going to come out okay, right? As long as I follow the recipe. Now, I don't want to go off script though, because I don't know the role of salt and fat and the difference between baking powder and baking sugar and what one does and what the other one does and what cream of tartar does to baking soda. I don't know all that. I'm not a chef. I'm a cook. I follow directions, right? Now, chefs, they can create new recipes because they understand the role of fat and salt and heat. And they know that if you cook, bake this at this temperature, this thermal reaction is going to occur. That's what they know. I don't know all that. I cook. I'm not a chef, right? So that's the difference between a CNA and a nurse. The CNA follows the recipe. But if you go off recipe, who knows what's going to come out? Right? Because we don't know what goes into it. We don't know all of those details. Nurses are the chefs. It's their job to know all of that background information. Make sense? Best analogy I can give you. All right, so we're going to show you this video for hand and nail care, and then we're going to go on break and hopefully reset. Hold on a minute. Hold on. Unmute me, Jake, please. Okay. All right. We're going to go on break first because our videos are not playing. So here's the deal. Those of you who are online, hopefully this will all go well. I may have to create a new live stream. Okay. Because once I get out of this one, I don't think it'll let me back in. It ends the live stream. So I'm probably going to have to create a new live stream. So you will see class 3 take 2. It'll pop up if you're subscribed. It'll pop up. So just click join. If you're not subscribed to my channel, subscribe to my channel so we can reach you for things like this. So we're going to take everything down, reboot everything. So hopefully we get rid of these glitches, but go to our YouTube channel, youtube.com/4YourCNA, and click on the new live stream, because once I get out of this live stream, it won't let me back in. Okay, we'll see you in 15 minutes. Okay, thank those of you who are attending virtually. We are working on our technical difficulties. We have reset everything on our end. Thankfully, we did not have to create a new stream. So you should be able to join us on here on this current stream. We will restart in about 8 minutes. I know the screen says 10, but it'll be about 8 minutes and we will restart class.
How long have you been learning? Oh, okay.
Go ahead and mute.
past my ruler and then they put also.
It's still glitchy, Jake.
Yeah.
It's still glitchy.
Yeah, let's try. Okay. So we are back. We've reset things on our end. I'm not real sure if the video is going to work. We're going to give it a try. If not, we were able to do this without resetting the stream. So keep your finger crossed. Hopefully the video will play. If not, we're going to have to scrap it and start all over. So let's go ahead and give the video a try, Jake.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the over bed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. And the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the overbed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. And the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin. Once the nails have been filed, we'll get some lotion. And we're going to warm the lotion up in our hands before we apply it to the patient's skin. So I'll rub my hands together to warm that lotion, apply it to all surfaces, making sure to coat all of the skin surfaces. And then we'll take that towel and wipe off the excess lotion. That way, it's not a slipping hazard if there's any lotion left on the surface of the skin. Now I'm going to take your linens and place them in dirty linen. I'll be right back.
Okay.
And I'm going to go clean your basin. I'll be right back. I'll bring the basin of water to the sink, dispose of the water into the sink, and rinse the basin. We'll dispose of the rinse water into the sink as well. I'll set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. I'll dry the inside with a clean paper towel. Throw that paper towel away. Dry the outside with a clean paper towel and throw that paper towel away, and then get one for the drawer. On the way, we'll pick up the soap and the lotion with the paper towel, place them in the basin, and use the paper towel to open the drawer. We'll slide the basin, soap, and lotion in the drawer and close it with the paper towel. Now we can dispose of our disposables.
So the emery board and the orange stick will go in the garbage along with the barrier. So we're just going to put these directly in the garbage can. Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm just going to move this table out of your way. Here's your call light, Mr. Jones. If you need anything at all, please press the button and let us know. We'll be happy to come help. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Good job, Jake. All right. Any questions on hand and nail care?
Yes. You didn't disinfect the base.
I said disinfect per facility policy.
Okay.
Because for the test, we're not going to disinfect.
Okay.
There is no disinfection for the test. It's just rinse, dry, and store. But we created the process so that if you have to disinfect it, you just slide that step right in. Everything else stays the same.
Ma'am, both hand clean, the one hand clean, and change the towels like you put on the 2 towels, one hand clean, and change the towel, the same towel like.
You can use the same towel. Same towel is fine.
Okay.
Follow the care plan. The care plan said one hand.
Only one hand clean.
For the care plan for this patient,
Okay.
yes. Other patients, probably 2 hands.
And it's just one towel and hand.
Yep. Yep. You use that towel for padding. You use that towel to dry the hand. You use that towel for the orange stick, and you use that towel to wipe off the lotion. Same towel. If you notice when I'm doing that, I use a different area of the towel, but you don't have to. Same towel's fine.
Can you use the barrier for the nail stick? Or?
Sure. Yeah, that's fine. Well, no, I'm sorry. That's not. If you go back and look at that checklist, I'm glad that I caught that. In a clinical setting, yes, it's fine. But if you go back and read the checklist itself, and let me pull it up so that I can show you guys, okay? So this is hand and nail care here. The checklist is back here. So if you ever have a question like that, you can look at the actual checklist for the test. But the checklist here says, hold on, I got to find it. Okay. Number 6, use flat edge of orange wood stick to remove residue under tips of each fingernail, and remove residue from edge of orange wood stick if present before using again to clean under another fingernail. So yes, it does not specifically say towel. I thought it did. Does not specifically say towel, so the barrier will be fine. It's as long as you clean the orange stick. A good question. Glad I verified that. So yes, that would be okay. Any others? No? Okay. Whew. We're late. Today is blood pressure day, and I got to get through. We're not going to get to range of motion. Again, it's okay. I'm going to push it off until a little bit later. I've got time at the end of the program to be able to get to. So we're going to learn making an occupied bed now, and then we're going to roll right into blood pressure because I'm short on time. Range of motion, those are the shortest skills. They're literally 4-minute. That's what they give you is 4-minute. It takes less than 2. So those are really quick skills for me to teach you later in the program. All right, so go to page 141. We're going to learn about changing an occupied bed. Oops, let me go back here. So if you look here, down the side, you can see all the principles. They're all spelled out for us here. We have all of the skill-specific steps, the short version, and down here is going to be our test-specific information. Somebody with your level of experience should be able to do this in 14 minutes or less. It is way quicker to change an unoccupied bed, one with nobody in it, than it is to change a bed with somebody in it. So if you see a bed with nobody in it, change the sheets. Okay. The patient's in a test, if the patient's at the dining room, if the patient's in the shower room, if the bed is empty and you know the sheets need to be changed, change it then. But there are some times where we are going to have to change the bed with the patient still in it, and we have to know how to do that. They're going to give you 14 minutes to do that. It does not take 14 minutes to do this skill. They're going to give you a lot of extra time, but this is a very physical skill. It does take a lot of physical activity to do this skill. Live patient will be in the bed so they can roll as directed, and they will be positioned obviously in the bed because this is changing the sheets with somebody in bed. Now, if you go to page 142, we have our step-by-step instructions. Care plans at the top of the page. Supplies are at the bottom. This is our the thing that we want to remember for this particular skill. Clean rolls toward me, dirty rolls away, and that's what we're going to learn first. So here's our care plan. It says change a top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed, but they just can't get out of bed. It says a bedspread, a blanket, a draw sheet, and an underpad is not required for this skill. Bottom sheet, top sheet, pillowcase, that's it. They're really, really making this the simplest form of this skill that you can do. Okay, good. All right. So in order to learn this particular skill, we have to learn the rest of linen rules. Now, we've learned all of this before, and we left these two blank. So remember, linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. Anything you don't use, you have to discard. We already know those things, but we have to learn these two additional steps. So the first one is clean rolls toward me, dirty rolls away. And the reason that we do it this way is because it allows us to layer dirty and clean when we're changing something under the patient. So this is going to apply to sheets. It can apply to draw sheets. It can apply to chucks. Anything under the patient, we're going to use this principle. Clean rolls toward me, dirty rolls away. And this is why. If I have a sheet on the bed, okay, can everybody see me? And I have a patient on the sheet, and this sheet is soiled, I need to change it. Clean rolls toward me, dirty rolls away. This is a dirty sheet, so I'm going to roll it away from me. And when I do that, it's the underside of the sheet that's facing up, not the part the patient was laying on. It's the underside of the sheet. Now, clean, new sheet, clean rolls toward me. And when I roll it toward me, it's the it's the underside of the sheet that's facing up. So I can then put this sheet underneath this sheet, tucking it in, and we've got a way of changing the sheets without what we call gross pathogen transfer, because it's just the undersides of the sheets that are touching. Now, what if this sheet is completely wet? Well, then this won't work all that well because you're putting a dry under a wet. It's going to get wet. So you could take a barrier, a chucks, and wrap it around this roll before you put this one there, because remember, chucks are waterproof. Good? Make sense? Do you guys understand why clean rolls toward me and dirty rolls away? Yeah. Then I have the patient roll back onto their back, and they're on this roll. I go around to the other side of the bed, have them roll away from me, and then I just take this one off of the bed and unroll that one. Put them back in the middle of the bed, and now I've got a clean sheet under the patient. Pretty cool, right? Okay. What's that? It actually, this isn't really a hard skill. It is physical. It is physical, but it's not hard. It's actually a pretty cool party trick. You know, might be able to make a couple bucks off this. I betcha I can change that sheet you laying in the bed and you never get out of it. Make a couple bucks. All right.
Is there a video on that?
Yeah, we're going to get there. Okay. Now, we don't let clean or dirty linens touch the floor. I've talked about this a lot. Nothing goes on the floor but feet, right? So this is probably the hardest step for you to internalize because, and that's why I keep harping on it, because when we change our sheets at home, where do you throw the sheets, the dirty ones? On the floor. Yeah, we're used to doing that. It's part of our normal activity. So you, during the test, may default to that. And that's why I'm very, very stringent about nothing goes on the floor but feet. Please keep that in mind because this is one skill that you're likely to violate that because it's just part of your routine. You can use the barrier on the table. Just keep your clean and dirty separate. That's fine. But there's a better way to do it. So in most cases, we want to put our dirty linens directly in a linen hamper. The problem is that they don't have them in the rooms. There are no hampers. We don't keep dirty stuff in the rooms. The hamper is out in a hallway somewhere, and you're not going to be carrying the sheets one at a time out of the room to the hallway. That's just way too much work. So what do we do with the sheets if there's no hamper in the room? Now, for the test, there will be a hamper right beside the bed. Yay, they make it so easy for us. But what do we do in a clinical setting when that's not the case? We're going to use what we call a blue bag or a soiled linen bag. This is a special bag, stamped soiled linen. It's light blue. And it actually, it's pretty cool because it's the original Tide Pods. We've been using these for like 50 years. The soap is actually impregnated into the bag. So when we put linens in this bag and send it off for cleaning, the whole bag, everything goes into the washer. The bag dissolves, releases the soap, and it cleans the linens. Now, that's important for us to know because when we're taking that sheet off of the bed, if there's hearing aids, dentures, earrings, cell phones, anything in that sheet and we don't catch it, it's going in the washer. Nobody's taking these sheets out and shaking them out to make sure there's nothing extra in that bag. So when we're changing the sheets, very important that we should be looking to make sure there's no foreign objects when we're removing these sheets. Okay. Hearing aids and dentures do not do well in high heat environments. Okay, good. Now, what if we can't find our soiled linen bags? What if they're missing, they're out, whatever? In that situation, or you're in a home care setting. In that situation, we still don't put stuff on the floor. We get a chucks and put it on the floor. When you put a chucks on the floor, that becomes your barrier. So you put a chucks on the floor, you put the dirty linen on the chucks, and then you can bundle it up to take it to wherever you're going to deposit it. But don't put the linens directly on the floor. Okay. I don't like this method, but it is available should you need to. For the test, you'll have a hamper. Easy peasy. Now that brings me to soiled linen rooms. In clinical settings, almost every congregate clinical setting, so whether it's a nursing home, a rehab, an ALF, whatever, hospital, you will have a special room that holds nothing but dirty stuff. So food trays that didn't get picked up on a food pass, they go in soiled utility. Dirty linens that you can't find a hamper for, they go in soiled utility. Bedside commodes that need to be washed, they go in soiled utility. This room holds everything dirty. Nothing clean can go into this room. Very important that you understand that. Nothing clean can cross that boundary. Everything in clean utility, nothing dirty, can go into. The only exception to that is your uniform. Remember, our uniform is not considered clean when we start work. So we don't want to lean up against a lot of surfaces and clean utility. Make sense? So we have a room specifically for clean stuff. We have a room specifically for dirty stuff, and you should not confuse the two. All right. We already know this. Use it or lose it on your linens. If you take too many pillowcases and you don't use them, don't leave them for later. They must be discarded. All right, so now we know all of linen rules. We're going to move on to scoot and roll. This is our last principle of the day that we're going to learn. Side rails cannot be used for safety on the state exam. Side rails are a restraint. You have to have a doctor's order to use them. You, as a CNA, cannot decide to use side rails. Me, as the nurse, cannot decide to use side rails. The only people that can decide to use side rails are doctors in a clinical setting. And that's because they are a restraint. If this patient, who is an adult, wants to get out of bed, this patient, who is an adult, has every right to get out of bed. Just like you do. I got up at 3 o'clock this morning. There is nobody standing beside my bed going, it's not time to get up, lay back down. I am an adult. If I wake up at 3 o'clock in the morning, I don't have to lay in bed. I can get my butt out of bed and go do something. Perfectly allowed. Just because this patient is in a clinical setting does not remove that right. And yet we put side rails up to keep patients where? In bed. That is a restraint. Okay. The real problem with side rails, most people use them for safety. Oh, I'm afraid of that patient falling. I hear that all the time by nurses. Oh, that patient's weak. They're going to fall. The side rails are up to remind them to stay in bed and call for help. Don't get up and wander by yourself because you're going to fall. Hear it all the time. Here's the problem. You put side rails up on that bed, keeps the patient confined in bed. What did you do to improve their stability? Nothing. And in fact, the longer they're in bed with side rails, the more their muscles will atrophy, shrink, break down. The more affected their coordination becomes. So you not only did nothing to improve, you actively sabotaged your patient, all in the name of safety. No, that was CYA. That was for you, not the patient. Do you guys see why side rails can't be used without a doctor's order? Because we don't make the right decision for the right party. We make a decision for our convenience. Good? Makes sense? So most hospitals won't even use side rails. Most hospitals hire sitters. That's you guys. You guys are all eligible to become a sitter. Go onto your local hospital's jobs website, look it up. There's probably sitter positions available. You sit by the side of the bed. That is your job. You don't do any patient care. You're not hands-on. You sit by the side of the bed and you are now the side rail. Okay. Notify the nurse when they try to get up. But your job is to keep them occupied, keep them distracted, take care of their needs, get them their water, turn on the TV, have a conversation, work on a puzzle. You're going to do something with them to keep them distracted. That's a sitter. The thing is, we don't need side rails to keep a patient safe. If the patient is in the middle of the bed, they are safe. That's where patients belong. So part of what we do as CNAs is to look at the patients to make sure they're always in the middle of the bed. Too far to one side, they're probably going to fall, and they feel that. Side rails are nothing more than a crib. We use cribs for babies. When this baby hits about 1.5, do they stay in the crib? What do? Yeah, they climb out. Now, this crib is no longer safe. It was safe when they weren't moving, but now it's not safe. Why? Yeah, because if they fall, they're not falling from here, they're falling from here, which increases the risk of injury. Same thing. Same thing. If your patient has side rails up and they have to get over them to get out of bed, you have risked bigger injury. You're not going to keep the patient in bed just because they have side rails. They will get around them or over them or through them. And side rails kill about 250 patients a year. Yep. So we can't use them without a doctor's order. Good? Make sense? All right. You don't need side rails to keep your patient safe. Keep them in the middle of the bed. Now, if they're turning on their side, that's where this gets tricky, right? Her on her back, she's in the middle of the bed, she's fine. But if I roll her on her side, she's going to be near the edge of the bed. That's not safe. Now, when you're in bed, you don't just roll over. That's right. You shift, okay? You pick your butt up and plant yourself on your side so your butt's in the same place, just facing a different direction. You don't roll, you shift. Okay, and if you don't believe me, go home, lay in bed, and roll over and feel how weird that is. No, you shift your butt. Okay, now if we're doing this on a patient, we can't just shift their butt. That it's too much weight for us to try to handle. So what we do is we scoot their whole body toward us, and then we roll them away from us, which serves the same purpose. You do it in one step, we do it on other people in two. Same process. That means they're on their side, but they're in the middle of the bed. Good? Now, for this skill, we want our patient on their side. We want them to take up the least amount of this bed as possible because we have to change the sheets around them. So we want a small footprint. We want them on their side. So I'll scoot them toward me, roll them up on their side, and then change that bottom sheet on that side of the bed. Good? Got it? Side rails kill people. Patients have to go over them, around them, under them, or through them. It increases risk of injury. And this right here is way more common than you would think. Way more common than you would think, especially if you have a confused patient. Okay? That's awful. That's awful. I was actually in a hospital working when this happened. Wasn't on my floor, thankfully, but it is awful. Because what's our job? What's our main job? Keep them safe. Yeah. Yeah. Remember, if there wasn't a safety concern, where would this person be? At home. That's right. So they send them to us to keep them safe. They think that they can't keep them safe at home. They're safer with trained professionals that can keep them safe. That is the whole reason anybody is anywhere but home. That is it. That is the whole reason. So if they put their loved ones in a facility to keep them safe, and we do something boneheaded that kills them, that never would have happened at home, did we help? No. We've got to remember why we do what we do. It's all about patient safety. It is not about your convenience. Now, here's the other problem with side rails. This happened here in Florida. There was a night shift at a nursing home here in Florida, and nursing homes usually lock the doors at somewhere around 10 o'clock. So nobody in, nobody out, right? Locks the doors for safety. That's for safety, isn't it? But it also means that loved ones can't come in and check on their loved ones. We lock them out. All in the name of safety. Well, this one night shift was giving every patient Benadryl, sometimes double and triple doses, put them in bed with their side rails up, and then spent the rest of the shift playing cards in the break room. And they did this for months. Months before they found out. We can't trust you with side rails. Even when I tell you, You cannot use side rails without a doctor's order. When you're on the night shift and the door is locked and nobody can come in and catch you, you'll put those side rails up because it makes your job easier. Even better if you can drug your patients and you don't have to do any work. You can collect that money for nothing. We can't trust caregivers. So most settings, you won't even have side rails on the bed. They won't even be there. If we get an order for side rails, we have to call maintenance and have maintenance come and put the side rails on the bed so we can use them. Isn't that awful? We should be way more trustworthy than that. Way more trustworthy than that. So if you find yourself working in a setting that is asking you to compromise your principles, probably not the setting you want to work at. Because every one of those people was charged. Yeah, not just had to go before the Board of Nursing. They were charged criminally for those actions. False imprisonment, unlawful use of narcotics. I mean, all kinds of charges. And all of them got jail time. And I'm okay with that. I am absolutely okay with that.
I mean, I don't know if it's true, but I heard like that much Benadryl for months. Doesn't that create like early onset something?
Oh yeah, yes, absolutely. It creates confusion. It can alter mental status on a permanent level. It changes the chemistry of the brain. We're finding out that Benadryl does all kinds of stuff. Yeah, all kinds of stuff. Yeah. All right, so let me explain to you the difference between half rails and full rails. This is a half rail. Okay, it only comes to about the patient's waist. This is okay. This is fine. We can use these. These are not a restraint. They don't keep the patient from getting out of bed. This patient can swing their legs out and get out of bed freely. This is positioning, helps them move around in the bed freely, perfectly okay. The minute I raise this one, that's a side rail. Got it? All right, so hospital beds and home care beds, same process. They just look a little bit different. Hospital beds are more like this, a little more electronic. Home care or nursing home beds are more of the tubular steel. It's the same thing. It looks a little different, but it's the same thing. It only comes down to the waist. Doesn't impede the legs. So to remain safe, the patient must be in the middle of the bed at all times. We call this the safe zone, and this is something that is graded, especially when they're turned on their side. If you look at your patient and they look like this, you took a wrong turn somewhere. All right, so we scoot them toward us and then we roll them away, but it's important that we roll them away. Okay, we roll them away from us. Do not roll a patient toward you, ever. There's two reasons for that. One of them is physics, the other is propriety. Physics tells us that most of our weight is distributed along our back, shoulders, back, hips, butt, thighs. Gravity is going to try to pull that patient onto their back. That's just physics. If their back, if you've rolled them towards you and gravity's trying to pull them away from you, that's way far for you to bend to stop that fall from happening. You're going to get injured or they are. Gravity is going to pull them onto their back. The other problem is if you turn that patient toward you, you are putting them face level with your crotch. And if you've got a patient that's ever been the victim of any sort of sexual abuse, they will react to that. That is not cool. We do not turn, and it can be seen as a threat, okay? We do not turn patients toward us. We always turn patients away from us. We can control their body weight then, and we're not indirectly threatening them. Make sense? I know it's not comfortable to talk about, but it's real. So always turn the patient away from you. And the way we remember this is we remain behind, the patient's behind. Okay? Side rails are not graded on the test. You have to provide safety without them. Even if there's side rails on the bed for the test, which there usually isn't, even if they're there, you can't rely on them for safety. The patient has to be in the middle of the bed. That's what they're grading on. Good? So now that we know these two principles, let's move on to our skills-specific steps. All right, there's a couple things about bed position. We have the head of the bed that can go up and down. We have the foot of the bed that can go up and down. And then we have the entire bed that can go up and down. These are the three ways that we can adjust beds. Now, in current times, we actually have beds you can buy at the mattress store that do these two things. Okay, that's kind of new. Okay, so these two things you can do with home mattresses a lot of times. What home mattresses don't do is this. This is only for healthcare, right here, only for healthcare. And why? Well, it's because we are working on patients that are in those beds. And if I'm having to do a lot of work on these patients, the bed is low. That means I have to bend over the patient, and 8 to 12 hours of this is going to kill my back. So we have the ability to raise the bed up to a comfortable working height for us. You do not have to raise the bed for any skill on the exam. But you can. Now, if you do, however, let me go back, raise that bed to a comfortable working height. And this is one skill you're probably going to want to, because it's a long skill, it's a physical skill, and it's all on the bed. If you raise that bed to a comfortable working height, what you did is move the floor. And let me explain. Time is my enemy today. Let me explain this, okay? So when you go to sleep at night and you swing your legs in and you go to sleep, you toss and you turn, when you wake up in the morning and you swing your legs out and you're groggy and not really paying attention, that floor has always been right where you left it. Has never moved a day in your life. Ever. It's predictable. The floor is always right where it's supposed to be. But when we come along and work on these patients and we raise the bed up and they swing their legs out, they expect that floor to be right where they left it, and it's not. So they step down into nothing. What's going to happen to these patients? They're going to fall. Yep. So lowering the bed is not about, I'm afraid my patient's going to roll out. That's not what that is. It's if the patient tries to get out of bed, that floor better be where they expect it to be, because they're not going to check to see. They've never checked to see. They've never had to check to see. That floor has to be where you left it. Good? Make sense? Okay. All right. So we never put a patient on a bare mattress. Well, that just kind of makes sense. So we don't take that soiled sheet away and then have them roll back onto a bare mattress. That's no good. You always want to roll the soiled sheet toward the patient and then put the new sheet on right away. Roll the clean toward you, tuck it up under that dirty, and then have them roll back onto their back so you can go to the other side of the bed. Don't take the dirty sheet all the way off and then try to put the clean sheet all the way on, because then your patient's laying on a bare mattress. Grace, good morning. So if there are side rails at the bed at the testing center, we won't fail any skills if we did not utilize them. Correct. Good job, Grace. You can use them if you want to. I don't suggest it. But if you use side rails, you still have to address safety in the other way by making sure your patient's in the middle of the bed. That's what you're being graded on. Now, a brief caveat to that. I don't know what state you're testing in. So, because we have viewers from everywhere. Florida and other Prometric testing states, that is the standard. There are, I think, 8 states that still test on the use of side rails. So please, what I'm telling you is based on Prometric testing. Please make sure you're checking with the standards of the testing company that your state uses in regards to side rails. Okay, so not on the bare mattress. So we're going to roll the old sheet or dirty sheet toward the patient, roll the clean sheet toward us, tuck the clean under the dirty with the patient on their side, tuck them under the patient. And then once we've got that change, this is what it looks like if we were to levitate the patient up out of the bed. This is what it would look like. And then once you do that, you go to the other side of the bed and repeat the process. Have them scoot toward you, roll away, take the dirty away, smooth out the clean, secure the corners. And now we have the patient on a clean sheet and they didn't have to get up. Questions on that? You want to try to remove as many wrinkles as you can out from under the patient. Wrinkles contribute to bed sores, and we're going to learn a little bit more about that on Wednesday. We're going to put the top sheet over the patient and secure the bottom of the sheet with hospital corners. If you don't know how to make hospital corners, the video is going to show you how. But get the corners of the sheet off the floor. What's allowed to touch the floor? Yeah, nothing but feet. That means if I've got corners of the sheet touching the floor, I took a wrong turn somewhere. Get the corners of the sheet under the mattress. That's what hospital corners do. It's just a pretty way of doing it. Good? Make sense? All right. If you use hospital corners or when you tuck the corners under the mattress, you want to loosen it over the toes because as you tuck that sheet under the mattress, it's going to pull those toes down. So loosen that sheet over the toes, give them some wiggle room, and then we'll change that pillowcase. Don't hold a pillowcase. We do this at home. Take the pillowcase off and then you put the pillow under your chin and shimmy that pillowcase up. That pillow has been drooled on, sneezed on, coughed on, all kinds of stuff on. You don't want to put it right here. No, don't do that. So we're going to use what I call the nightcap method. Take the old pillowcase off, put your pillow on your working surface, scrunch up your pillowcase and put it on the top of the pillow like a nightcap. Then hold the top of the pillow and pull the sides down. You never have to hold it under your chin. In fact, it shouldn't ever touch your uniform. Good? Good? Limit the amount of time the patient is without a pillow. We want to do this pretty quickly. Don't take the pillow off before you ever start the skill. It's a lot of time without a pillow. So we're going to change the bottom sheet, change top sheet, tuck our hospital corners, and then remove the pillow. So now we know everything we need to know to do this skill. Let's use these principles to fill out this checklist and see how we're going to get 100%. We're going to follow the care plan. We're going to do our opening. We're going to evaluate if we need gloves. Now, time out here. You're going to be a patient for this, for the test. You're going to be a patient for this, for the test. You're going to be a patient for this, for the test. So you're laying in bed. You come to the testing center fully clothed. And you know what? During the test, you're going to stay fully clothed. You guys all probably hold on to your own body fluids like a champ. So for the test, I am not touching any body fluids. I am not touching any personal skin. You're fully clothed. And I am not touching any non-intact skin. You're fully clothed. So for the test, there is nothing that makes me need gloves. Now, if I'm working on a patient who has on no undergarments and just a hospital gown, then yeah, I'm going to be touching personal skin. I need some gloves. If I'm working on a patient who is incontinent, I need some gloves. If I'm working on a patient that has an incision, I need some gloves. So you're going to evaluate it based on the situation you're working with. Make sense? Good? So we'll evaluate if we need gloves. We're going to use a barrier and we'll get a privacy blanket because anytime our patient is uncovered or undressed, we need a privacy blanket. We're going to use our linen rules. Don't hold them up next to your uniform. Nothing goes on the floor. Use what you take. Clean rolls toward me, dirty rolls away. Patient's always going to be in the middle of the bed. For this skill, we're going to use all of the steps we just talked about, and we're going to do our closing. And if we do all of that together, we will get 100% on the state exam. This care plan is only for that patient, nobody else. This person, different care plan. This person gets out of bed. I change his bed without him in it. This one needs a bed change every hour because his fever just broke and he's sweating horribly. So I'm changing his sheets every hour. And he doesn't feel he's had a fever break, right? So I may need an extra blanket with him. Every care plan is going to be different. We're only worried about this one right here for this patient. Make sense? You guys understand how those care plans work? All right, let's try a video. You know my horoscope today? This is crazy. This is absolutely insane. My horoscope today told me I was going to have technical difficulties. Crazy, absolutely crazy. I should have taken a screenshot of it. I was reading it this morning. I thought, I haven't had any problems with my tech in months. No problem. He can tell you, no problems with tech in months. This can't be, it must be something else. Crazy. And I'm not really a believer in all that stuff, but crazy. No, it just happened to show up on my Facebook feed.
That's funny.
Yep.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket. We're going to start with the bottom sheet. So I'm going to place a privacy blanket over you. This is going to help keep you warm and provide some privacy as we do this skill. So I'll spread this out, being careful not to shake it or snap it, and lay it in place. I'm going to pull your top sheet all the way down, and we'll remove it from the bed. Wrapping it in a ball so that the trailing edges don't contaminate other surfaces. We're going to lay this on an unused part of the barrier on the table. Mr. Jones, can you scoot your whole body toward me? And then I'm going to ask you to roll to that side so you're in the middle of the bed. Thank you. We're going to remove the sheet from the top and the bottom of the bed, and we'll roll this toward the patient. Dirty always rolls toward the patient. And we're going to tuck this in under the patient's body, all along the length of their body. Now we'll take the clean sheet, unfold it, and spread it out on the mattress, being careful not to shake it or snap it or let it touch the floor. We'll secure the corners. And then we'll take the clean sheet and roll it toward us to minimize wrinkles. And then we're going to lift the bottom sheet and tuck this clean sheet underneath the bottom sheet, all along the length of the body. So we'll roll it toward us. And then tuck it underneath the soiled sheet. You want to minimize the wrinkles that are under the patient. All right, Mr. Jones, can you come back onto your back and scoot to the middle? You'll feel a big roll. Okay, I'm going to go to the other side of the bed now. Can you scoot toward me, please? And then roll on your side so you're facing that direction. Thank you. We're going to remove the bottom sheet from the bed, rolling it in a ball. And then we'll place this with our other soiled items on the overbed table. We'll stretch out the clean sheet. Attach the corners. Minimizing the wrinkles underneath the patient. Okay, Mr. Jones, can you come back onto your back and scoot to the middle, please? Okay. Now we'll put the top sheet on. We want to open this up and spread it out, being careful not to snap it or shake it. We'll lay this over the patient. Making sure that there's an equal amount of sheet on each side of the bed. And then we're going to tuck the sheet under the mattress. So we'll lift the mattress and pull the sheet so that it's flat under the mattress. We're going to come down about a foot from the end of the bed, pick it straight up. You'll see a triangle here, and tuck in the bottom. We're going to lift the mattress from below, tuck the sheet so that it's flat under the mattress. Come down about a foot from the end of the bed, pick the top flap straight up. You'll see a triangle. Tuck everything else in. We're going to loosen this over the toes. And now I can remove your privacy blanket. I'm going to roll this into a ball and place it with our other dirty items. Mr. Jones, can I take your pillow? I'll bring it right back. We'll remove the pillowcase by holding the pillow and sliding the pillowcase down. We're going to place this with our other soiled items and put the pillow on the table. We'll take the pillowcase, scrunch it all the way up to the corners, and the tag side of the pillow will go into the pillowcase. So we'll stand it up, slide the pillowcase over the pillow, hold the whole pillow and pillowcase, and slide the sides down. The opening of the pillowcase is going to face away from the door. Mr. Jones, can you lift your head up for me? Thank you very much. Are you comfortable?
Yes.
Let me dispose of my supplies, and I'll be right back.
Okay.
These are going to go into dirty linen. And then we'll dispose of our barrier. We'll place our table back and make sure our environment is clean. All right, Mr. Jones, is there anything else I can help you with?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your call light is right here. If you need anything, just press that red button. We'll be happy to help you.
Thank you.
Bed is in the low position. Environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Okay, any questions?
Yes, ma'am.
Yes.
That person is conscious, ma'am, and move on the like a self position.
For the test.
Unconscious patient change the like bed sheet.
We're going to talk about working with immobile patients next class.
Thank you, ma'am.
You're welcome. All right. Any other questions? Okay, we are going to move on because we're going to skip that one. Okay. Go to page 56 in your book. Blood pressure is not on the state exam. You are not going to have to demonstrate taking a blood pressure for the state exam. Not with a manual cuff, not with an automated cuff. Blood pressure skill is not on the state exam. You do need to know how for two reasons. It could be on the written test. So you have to know your normals and you have to know procedure. And in a clinical setting, you may have to take a manual blood pressure because if you're using a machine and you get an abnormal reading, we have to double check it manually to make sure it's a problem with the patient. It could be a problem with the machine. Okay. So you do have to learn how to do this, but you will not be tested on it on the state exam. So these are the notes for what I'm about to go over with you. And we learned this already last week. We have a heart on the left side of our chest. That heart squeezes, pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. That wave pushes the one in front of it. This is how blood moves through your circulatory system. If you remember with pulse, what we did was we pushed down on this artery and felt these waves as they moved by and counted them. This time, with blood pressure, same underlying mechanism here, but instead of counting the waves, we want to see how much pressure is inside this artery when a wave is moving through and how much pressure is there in between the waves. This is our top number of our blood pressure or our systolic. This is the bottom number of our blood pressure or our diastolic. Okay? But it's the same artery. Same waves. With pulse, we count the waves. With blood pressure, we measure how much pressure is in each one of these areas. All right, good. I'm going to show you how to do that. All right, so when the heart squeezes and pushes out that wave of blood, this thump, this wave is produced when the heart contracts. So it's the maximum amount of pressure. And that's why we call it the systolic. It's the squeezing, the maximum pressure. In between waves, the heart is actually at rest, or that's our diastolic number. And that's the amount of pressure in between waves. So think of like our hose, right? The hose doesn't completely collapse when there's no water in it. It still has some structure when you have a hose outside attached to your faucet. So same thing with your blood vessels. They don't completely collapse in between the waves. There's still some structure there. How much structure? That's the bottom number of your blood pressure. Normal values for the top number or systolic, normal is between 100 and 119. This is on page, I think it's 57 in your book, near the top of the first column. Normal is between 100 and 119 for the top number. Bottom number, normal, between 60 and 79. So that's what we're hoping for. That's what we want to see. If either of those values are not in those ranges, what do you do with that information? Notify the nurse. Yep. So in order to get these measurements, we have to use some equipment. And this is a sphygmomanometer, also called a blood pressure gauge, but its technical name is a sphygmomanometer. What we're going to do is wrap the cuff around the arm, and we're going to inflate our cuff so the needle goes up, 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 and we stop as CNAs somewhere between 160 and 180. This is our stopping point here. So we inflate the cuff somewhere between 160 and 180. And then we're going to deflate the cuff by letting the air out slowly. And this needle is going to drop slowly and hopefully steadily. If the needle stops, that's you. You need to let more air out. If the needle goes, woo, that's you. You let the air out too fast. So the way this needle descends, you are in complete control of. Good? We're going to learn how to do that in just a minute. So we inflate to somewhere between 160 and 180. We deflate controlled smooth, that needle. And along the way, we're going to listen for some sounds. We're going to listen for the first thump that we hear. And we're going to listen for the last clear thump that we hear. The first thump, where the needle is on that dial, is our top number. The last thump, the last clear thump, where the needle is on that dial, is our bottom number. We're not counting thumps. It's the first thump we hear and the last clear thump that we hear. Top number, bottom number. Got it? Okay, so we're listening for the first thump. First means nothing is coming before it. First is first, right? So that means when we inflate this cuff and the needle starts to come down, it's going to be quiet. Quiet, 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 quiet. Nothing happening, and your brain is going to convince yourself that you've missed it. I'm not hearing anything. Something is wrong. I don't know what I'm doing here. I don't hear. You're not supposed to hear anything. Remember, normal is right here. Between these two lines is where we should hear the first thump, if it's normal. Remember, we went all the way up to here. So there's a whole lot of quiet before we get to normal. Now, chances are most people don't have normal blood pressure. Most people's blood pressure in America is a little bit high. So chances are you'll probably hear it somewhere around here. But still, it's quiet before you hear that first one. Then you're going to hear, once you hear one, you hear more. Thump, 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 thump. And they're going to get significantly lighter as they go. So thump, 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 thump. Where was the last clear thump? And that is your bottom number. Then there won't be any after because it was the last one. Last means nobody after. And you're going to deflate all the way back to 0. First number, last number. Got it? Good? So it's not hard, okay, in theory, not hard. But there's a lot going on here. Your hand has to control the inflation and deflation of this cuff. Your ears have to listen for the thumps. Your eyes have to watch where that needle is when those thumps occur. And your brain has to work out what number was that needle pointing to when the ear heard the thump. So lots going on in here. Okay. In theory, it's pretty simple. Inflate, deflate, listen for the first, listen for the last. But this takes some practice to get down. So in this class, in just a few minutes, we're going to practice this. I'm going to explain to you what's happening inside the body when we're doing this. But we're going to practice in here. These cuffs that you guys have are for classroom use. So I don't send them home with you. You don't have cuffs to go home and practice with. I suggest if you want to practice this more, you buy a cuff off of Amazon. Okay, or go to, I don't recommend the ones at like Walgreens or Walmart because those are usually what we call home cuffs or self cuffs.
the stethoscope is attached to the cuff. So it's harder to use on a professional level. I would go to Amazon. I mean, they've got them for like $20 a set. You know, it's pretty reasonable. But remember, this isn't a tested skill. Okay. I used to make all my students buy their own blood pressure cuffs and stethoscopes to come to class. The problem was that once you learn this, most settings don't have you taking manual blood pressure. So you bought this kit and you're never going to use it again. And yeah, I got complaints from students and I get it. So I have a classroom set for you guys to practice with. But if you want more practice, please remember that you can buy your own. So let's learn how to use this equipment. Okay, so each one of you and your little kits, go ahead and unzip them. You'll have a stethoscope and a blood pressure cuff. And we're going to learn about this equipment now. Okay, stethoscope is nothing more. If you've got a little pieces parts kit, just put it back in the bag. You don't need it. This is nothing more than a microphone with ear tips. That's all it is. It's a microphone. And it's designed to amplify. But it doesn't amplify both sides. We have to tell it which side we want amplified. So I'm going to show you a little bit about that. But this end, the head of the stethoscope, okay, this is called a head. This is the microphone end. Now, this microphone comes in a couple of different varieties. You may have a single tube, you may have a double tube, doesn't matter, they both work the same. The head of the stethoscope, if it's flat, it's called a diaphragm. If it's cupped, it's called a bell. Now, as CNAs, the only side we use is the large diaphragm. I am trying to hear a wave of blood moving through an artery buried under muscle, fat, and tissue. This is not a big sound, guys. I want the biggest microphone I can get. So we're going to use the large side. Good? Good. Remember, both of these are not on at the same time. If it was, then the AC would be amplified. You know, bouncing your leg would be amplified. It would amplify all the outside. I only want what I'm listening to amplified. So we actually have to tell this thing which side we're listening to. And on your stethoscope down here, you may have a little dot like this. You see your little dot? Okay, this whole thing turns. The whole thing turns. So if I want to listen through the bell, I can. But I want the large diaphragm. So make sure that your large diaphragm is facing the same direction as your dot. If not, just flip this thing around. Good? Good? Okay. Most of yours should be set up that way. Okay. Ear tips are the most misunderstood part of this contraption. Everybody puts these things in wrong. Ear tips should not be straight. Okay, if your ear tips look like this, that's not how we use them. Ear tips need to be angled slightly. That's a little too much. Angled slightly, and they actually move. These earpieces move. You can twist them. You can actually turn them all the way around if you want to. But you want to make sure that they're slightly angled. Slightly angled. Okay, some of them have already been set up for you. Some of them you have to adjust. But the ear tips should be slightly angled. And this is how they go in. When you're putting your ear tips in, this is why I said everybody gets this wrong. When you're putting them in, they have to face away from you. Away from you. Not toward you. Away from you. So put these in your ears facing away from you and then tap your diaphragm. You should hear it. Now take them out. Just flip the whole thing backwards. Put them in and try that again.
Try it again. You probably can't hear as well. So turn it back around the right way. Put your ear tips in, and they should seat better, and you should hear the sound much clearer. Do you guys see that? When I had the retail store, people would buy the high-end stethoscopes, and then they would bring them back and complain they were broken. And I'd say, okay, could you just do me a favor? Just try them now. And they would, oh, you fixed it. And these people are handling meds. All right. So make sure that you're using your, this is the number one reason people can't hear a blood pressure, by the way, is you put your ear tips in the wrong way. If you can't hear the blood pressure, check your stethoscope. It's probably you put them in backwards. Probably. All right, let's move on to the blood pressure cuff. So the blood pressure cuff is what is going to give us the numbers. This is nothing more than a tourniquet. Have you ever gone to have blood taken? You know how they wrap the latex thing around your arm, right? That's all this is. But it's one we can control with air. This gauge is what gives us the numbers. This occludes the artery. This gives us the numbers. They're attached together, but they're two different parts, and we have to know the difference. All right, do not, while I'm talking, do not inflate your cuff. If it's not wrapped around something, you will knock it out of calibration. And every class, I always have somebody that's really anxious and they just start inflating their cuff. And I don't want my kits to go out of calibration. Okay, it has to be wrapped around something. It has to have something to press against. Okay. All right, so we're going to learn how to read this dial. So when you're looking at this dial, and you can look at yours as I go through this, you can see numbers all the way around, and they're marked in 20s, 20, 40, 60, 80, 100. These lines in between are your 10. So that's 20. This is 30. Even though it doesn't have a 30 there, I know it's 30. 40, 50, 60, 70, 80, 90. Good? All right, now these little itty bitty teeny tiny lines, those are 2s. So if this is a line for 60, that's 62, 64, 66, 68, and there's my 70. You cannot, on this dial, point to 139. There is no line for 139. So if you give me an odd number, I know you're guessing. If you tell me the blood pressure is 117 over 63, you have no clue. I have to go in and check it. Now, automated machines can be that precise. We cannot. So when you're reporting blood pressures, report them using even numbers, because that's what this gauge is giving you, even numbers. Got it? Good? Really important, because there are really old nurses out there that will absolutely corner you on this. And they're mean. I have worked with some nurses that are mean. And they will pull that out and they'll tell you, point to 137. You told me in a medical record, legal document, that you got 137. You show me 130. Oh, it's a space. No, spaces. No, numbers, lines. We don't do spaces. Not in medicine. They are mean. Don't fall into that trap, because we do have one here in the county. Be careful. Even numbers. I'm trying to save you here. Okay. All right. So how do we get these numbers? Well, on your cuff, you have a gauge that should be attached to your cuff, and you have this thing hanging off called a bulb and valve assembly. This bulb and valve assembly is how we're going to put air in and take air out of our cuff. And we want to hold this in our hands so the tube points up. Now, don't inflate your cuff yet, but you want to hold it so the tube points up, and you want to be able to get to this little silver dial in my hand between your thumb and index finger. Now, this dial you should not let go of. I want you to treat this kind of like a hand grenade, right? Once you pull the pin, can't let go. That's this. Because what ends up happening, especially with new students, is you're going to tighten it to inflate the cuff, and then we have to open it up, okay? So when we open it, if you pull your fingers away from it as the needle starts to go, you have to keep opening it. It's not just one and done. When you put your hand back on it, you end up moving that dial, and now you're not accurate. So when you're holding this dial, hold it. Don't let go. Keep your fingers there and adjust. Make sense? Good? Okay. All right. So this dial, turning it is how we're going to put air in and let air out. Righty-tighty, lefty-loosey. If it's facing you, righty-tighty, lefty-loosey. All right. You're going to turn it just till it stops. You're going to inflate it. You're going to turn the little dial to deflate. The needle's going to come down. We're listening for first and last clear. Good? Kind of got the mechanics just a little bit? Okay. So let me explain to you what's happening on the inside of the body, just for visual, okay? When we put the cuff around the arm, the upper arm, blood is still flowing through. We haven't inflated the cuff yet. We just wrapped it around the arm. Blood is still going through. Now, once we inflate that cuff, that air pressure, as this needle goes up, that air pressure presses in. Remember I said it had to press against something? It presses in, and it uses your muscles. As it presses in, it closes off that artery. Okay. This hand now has no blood flowing to it. Leave it that way for too long, it's going to reach up and slap you. Okay. We want to do this somewhat quickly. This hurts after a while. Okay. So don't inflate yet. Okay. So we inflate our cuff and we squeeze off that artery. Now, once we get up to somewhere around 160, 180, we're going to put our stethoscope in our ears, and we're going to put the diaphragm here over the artery. We are listening for a wave of blood hitting the top of an artery. Got to make sure you're on the artery. Okay, good so far? Got it? Okay, as we deflate the cuff, the pressure relinquishes a little bit. Pressure decreases a little bit. We're moving that dial, teeny tiny movements, hairs, teeny tiny movements. As we do, that needle starts to come down slowly. You are in control of that needle. If it moves too fast, that's you. If it stops, that's you. Good? Good? We're going to practice it. It'll come all together in just a minute. All right. I'm just explaining what's happening inside. So as that pressure decreases, the artery opens up. And those waves that were stacked on top waiting to get through, they're finally able to squeeze through this little tiny opening. And as they squeeze through this little tiny opening, and our stethoscope is right here, we hear the first one. That's our first thump. Well, if the first one was able to go through, others can go through. We're going to hear more. But that's our first thump. So as those waves start to come through, we hear that first one. So quiet, quiet, quiet thump. There it is. We want to pay attention to where we hear that first one and where that needle is on our dial. These thumps are called Korotkov sounds. That's its technical name, a Korotkov sound, because the guy who figured this out's name was Korotkov. We want to pay attention. Where is that needle when we heard that first thump? Now, this one, here's our 100, 2, 4, 6, 8. So what is this person's top number of their blood pressure? 108. This is where the needle is. When we heard that first thump, that is the top number of our blood pressure. Good? Now, so 108. Now, if we heard the first thump, we're going to hear more. Thump, 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 thump. Those are just, all those thumps are just more waves going through because the artery is getting bigger and bigger and bigger and bigger and bigger because we're letting the air out bigger and bigger and bigger. And at some point, the pressure is going to be so much that that wave isn't going to hit the top of the artery anymore. We actually have to compress the artery for us to hear the wave of blood hitting the top of it. So at some point, when we get toward the bottom, those sounds are going to disappear because now our artery is wide open. That's what we're listening for. Where is the point that we stop hearing sounds? So we heard the first one. That was our top number. We heard a thump here and here and here, thump, thump, thump. Where's the last one? So our last one is right here. So one little line above 60, 62. So our blood pressure for this patient, when we stop hearing sounds, is where we heard the first thump and where we heard the last clear thump. So in this case, it's 108 over 62. Now we've heard the last one. We're going to keep listening because there could be another one. That might have been the last one, but we won't know until another one doesn't show up, right? So we're going to keep listening, and then we're going to make sure we get all the way to 0 before we take the cuff off. Good. So we inflate somewhere between 160 and 180. We deflate slowly and smoothly. We'll listen for the first thump. Where's the needle? That's our top number. We hear more thumps. Don't care about those. We're listening for the last clear thump. Where's the needle? That's our bottom number. And we deflate to 0. Hopefully, our numbers are in normal ranges. What do we do if either one of those numbers is outside of normal range? What do we do if both numbers are outside of the normal range? Tell the nurse. Probably a little quicker. You know, one number outside, that's a problem. 2 numbers outside could be a big problem. I do too. All right, so keep deflating until your needle reaches 0. Then remove and record the reading. So the first thunk, where the needle is, top number. Last thunk, where the needle is, bottom number. Okay, good. All right, so in your book on page 57, you have this review area here. Let's look at this image right here. I know it's kind of hard to read in the black and white, but you should be able to make it out pretty close. Where is that top, that first thump? 110. Where did you hear the last thump?
62.
So, say it again. This one over here. So the top where we heard the first thump is between 120 and 140. So what is that line? 130. The bottom number where we heard it is between 80 and 100. What is that line? 90. So what is this person's blood pressure? 130 over 90. Is that normal? What do we do with that? Report it to the nurse. Let's look at this one. Yeah, so let's look at this one. So this one, where we heard the first thump, is just under that 120 or 110 mark. What is that? What is one tick below 110? 108. And the last thump we heard was one tick above 60. So what would that be? 62. So what is this person's blood pressure? 108 over 62. Got it? Got it? Okay, there's more information here that I want you to read sometime whenever. about, feet flat on the floor or ask which aren't. This is all information that could be on your written exam that we're not going to go over in class because I want you to practice the mechanics of this. So take your can, take your cuff, put the cuff around the can so that the gauge is facing out and the tubes are hanging down. Your cuff should look like this around your can. Go ahead and secure it with the Velcro. There you go. Okay, you got this big flap hanging out here. What I want you to do is hold the can in your non-dominant hand. So I'm right-handed, so this is going to be held in my left hand, tucking that flap behind just to get it out of the way so I can see. And in my dominant hand, I am going to hold my bulb and valve assembly. All right, Jake, you're going to zoom. All right, this is what it should look like. Now pay attention to, I'm going to try to do this where it's not so glary. So pay attention. This is my dial. This is how I control it. This is my gauge. Watch what's happening there. So I'm going to turn my dial just until it stops. I'm not going to tighten it. Notice I'm not, really tightening it just until it stops. I'm going to squeeze to put air in. I'm going to go up to between 160 and 180. And then I'm going to hold that dial between my index finger and thumb, and I'm going to open it just ever so slightly. My needle should go down at about that rate. You guys see that rate? Now, it's not a crock pot. I can't set it and forget it. See how it's slowing down? I got to open it a little more. It'll slow down. I got to open it a little more. I got to open it a little more. I got to open it a little more. And now I've really got to open it to get the rest of that air out. Got it? Got it? So one more time. Yeah. One more time. I'm going to close this. I'm going to pump it up. I'm going to hold that dial between my thumb and index finger, and I'm going to open it ever so slightly. So my needle goes down at about that rate. And as it starts to slow down, I got to open it a little more, 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 and open. Go ahead and give it a couple tries. If your needle is not going up, it means your valve is not closed.
Are you supposed to open it back up all the way? Or?
Yeah, open it all the way. I'm going to come around. Keep opening. Keep opening. Other way. You want to turn it that way to open, that way to close.
So this is opening, this is closed, right?
Yep. So we want to open, open, open. Okay, now close it. Okay, now inflate. Pump it. Okay, good. Open it just a little bit. A little too much. There you go. A little more. Oh, good. You want to keep that rate. So see how it's starting to slow down? Open a little more. Good. Good. All the way down. Yep. Open it so it goes all the way down. Yeah, when it goes to 0, you take it off of the patient. Or if you want to start again, you would close it.
It's so sensitive.
It's very sensitive. Yeah.
Yeah, that's a little bit faster. It's going to be hard for you to hear the thumps and put it with the numbers. So you want to slow down just a little bit. A little more practice. You got it, though. You got the mechanics. Yeah, a little too fast. Yeah, and that's why you don't want to over tighten it, because then you really have to, and that's when the needle goes way down. So that's why I don't like really over tighten it when I close it. Just close it till it's closed. Don't tighten it. Go ahead. Better, better. Good, good. Okay, go ahead.
Yes, ma'am. Ma'am, my English not good, but I check
Okay,
good.
you're good on blood pressure.
Everything, yes, ma'am.
Okay.
Like stethoscope use and 2 fingers up, one
Okay,
sound, like slowly, like
Yep.
sound up and down.
okay, good. Good control. Nice. Well done. Awesome. A little bit more. Awesome. Good job. Good job. Okay. Go ahead and inflate for me. Okay, go ahead and close it. Inflate. You want to go up here. Good. Don't let it stop. Keep opening a little more, a little more, a little more, a little more. Keep going. Good. That's your rate right there. You got to keep opening it to keep that rate, though. It'll slow down on you.
Recommend taking your own blood pressure? with
Very
blood
good.
pressure?
Little bit faster, but you've got the mechanics. Good. Yeah, I know. As soon as I show up, I get it. All right. So the question is, can you take your own blood pressure? And the answer is, if you had one more hand, you could, but you don't have enough hands. Yeah. The problem is that you cannot, the arm you're taking the blood pressure on cannot be doing anything. It has to just lay there. One hand has to control the thumper, the bulb and valve assembly. The other hand has to hold the stethoscope. So you need one more hand to make it work. And that's where those cuffs that you can get at Walgreens and Walmart are good, because the stethoscope is actually built into the cuff. So that takes away the one hand problem. But they're not a good investment for CNAs, is what I'm saying. All right. So do you guys have a vague understanding of the mechanics of this? Remember, you will not be doing this for the state exam, not a skill you'll have to demonstrate. But you do have to understand the mechanics of it, because you may have some questions on the written exam about it. So read the rest of the content here, okay, to make sure you get that covered. And anybody have any questions about blood pressure? What's that? Oh, in just a minute, yeah.
So do I loosen it after it drops from 160? Like, let it do its course?
So on the can, it's automatically going to drop because the can has pressure. So when you get up to 160, it may come down just a little bit on its own, and that's just pressure dynamics. As it just
when you get up there, just start opening.
Okay.
Just, start bringing it down. Okay. Any others? Jake, review sheets. They're going to need the pink one as well as class 3. Okay, so your homework tonight is just one chapter, chapter 4. Remember I said I know 4 hours ago was a long time ago. I told you I didn't like chapter 4. So the pink sheet that Jake's going to give you is going to help you kind of distill all of that information into what you need to know. All right? So don't get into the weeds on chapter 4. The pink sheet will help you with what you need out of that information. You're going to get your wrap-up email. I hope that the video came out okay on YouTube, your replay, but you'll have links to all of the skills videos if you need to rewatch any of them. CPR class, you've got this QR code on day 1, the blue sheet that I gave you, and this is the pink sheet I'm talking about, okay? Those of you that are attending virtually, I do not have this up on the website yet for you guys to print out. I'm sorry. I'll work on that sometime in the next week.
You have to do applications to get pre-approved to take the state exam.
We're going through that on Wednesday. We go through, I have a whole hour lecture on the state exam. I give you the applications. We fill them out in class together. Okay. All right. So those of you that are joining us virtually, thank you so much for tuning in today. Sorry about the technical difficulties. We will see you on Wednesday for class 4, and that's when we'll go over test registration processes. Thanks for hanging in there throughout all of our trials and tribulations today. And until next time, happy caregiving. Bye.